and the awareness of disinfection protocols, processes, operational, and workload planning to accommodate disinfection, decontamination, and also the knowledge of compatibility of disinfection on material equipment. There's some other compounds that infected the solution, like hypochlorite, chlorine dioxide, ammonia compound, and other disinfectants, also ozone, hydrogen peroxide. All of these are the common disinfectants. Who should provide cleaning services? It has been a topic of debate within nursing for some time. Current service provision falls in two areas. In-house clinic services were employed by and managed by each organization, or contracted clinic services provided by the third party. Clinic service providers can be appointed following a competitive tender. Historically, it has been perceived that in-house clinic services provide a superior standard of clinics. Although there is no evidence to support this, this perception may have arisen due to assumptions that cost as a major factor in the provision of clinic services has led to deterioration in standards. The provision of clear organizational strategy that describes the organization, overreaching strategy for maintaining a clean and safe environment for patients and staff, and commitments to a continuous service improvement. A clearly defined responsibilities for specific staff groups with respect to achieve a standard and accountability arrangement, education and training. Assurance process and monitoring, use of equipment, learning from incidents. Linking to and cross-reference other co-organization standards and policies such as infection prevention and control, outbreaks, or major incident, bed management, and food hygiene. Support for nursing staff to ensure high standard cleanliness is reflected in principles. Keeping NHS clean is everybody's responsibility. The patient environment will be well maintained, clean, and safe. Matrons will establish a cleanliness culture across their units. Cleaning staff will be recognized for important work they do. Specific rules and responsibility for cleaning will be clear. Patients will have a part to play in monitoring and reporting on standards of cleanliness. Nurses and infection control teams will be involved in drawing up cleaning contracts and matrons. It is dependent on human relationships and contamination and communication. Understanding each other's roles, responsibilities, and priorities is central to a successful working relationship between nurses and domestic staff. Favorable services and patient outcomes. This is clearly an area of further investigation and description as a part of current focus on workplace and organization culture to improve patient safety generally. The frequency and methods of monitoring standards of cleanliness will be defined for each cleaning service regardless of provider. The frequency of cleaning undertaken will depend on how the contract is written. The frequency of cleaning also depends on risk associated with each functional area. Monitoring process includes auditing cleanliness against agreed standard at frequency agreed within the organization contract. Contracts will specify how staff training is undertaken on and how assessment of cleanliness will be made. The principle of recertification of issues can include the following. Each technical audit should be underperformance of a standard as highlighted by low audit scores over a period of time, result in the remedial action plans and increase the frequency of audits. Management audit and area may also take place. Continued underperformance of the cleaning service will result in escalation and formal written recertification plan. For a third-party contracted services provider, a payment mechanism which deducts the payment provider's compensation in the event of underperformance. Education and training of staff is central to the development of competent workforce. Elements of domestic staff training programs include how to clean, cleaning protocols for a specific environment, use of cleaning material, buffing spray cleaning, color coding of equipments and accessories, use of protective clothing, infection prevention, constitution and use of chemicals, equipment safe use and care. For nursing, from nursing perspective, the following issues are central to a successful decontamination and the provision of a safe patient equipment. Staff are aware that the decontamination life cycle of equipment begins when items are considered for purchase in order to avoid the purchase of equipment that cannot be decontaminated effectively. The organization has in place a comprehensive equipment cleaning strategy and decontamination policy that staff can easily assess. Local policies and procedures are explicit with regard to responsibility for cleaning items before and after use. Hand washing basins are not used for cleaning of reusable patient equipment. Should disinfection be required, policies provide information on what disinfectant should be used and its method of application used. Staff who decontaminate equipment have been trained in how to undertake this and have been assessed as competent. Records are maintained that document decontamination following use. Sufficient equipment is available to permit turnaround time between use and decontamination. Regular monitoring of the cleanliness of reusable patient equipment is undertaken. Patient equipment falls in two broad categories, single-use and reusable. Reusable patient equipment is predominantly decontaminated and stored at War Department level. The pressure on availability of equipment and turnaround time for use by patient can be very high, resulting in pressure to undertake the task quickly. The use of single-use equipment is driven by risk, ability to decontaminate, and cost. Single-use equipment should not be reused and can be distinguished from the reusable equipment by simple tool with a line drawn through it. Several forms of wipes may be in use at any one time within an organization. It is important that staff using these items understand the difference between patient care wipes, disinfectant wipes used to disinfect the environment or patient equipment, and general detergent cleaning wipes. Confusion over which type of wipe to use pose a potential risk to patients. Whilst detergent wipe enables the release of physical dirt from surfaces, not all microorganisms are removed and destroyed. Additional application of disinfection wipes may be of benefit, but is limited due to a number of factors, like detergency of the wipe, effectiveness of the disinfectant, use of wipe by staff, the level of challenge of physical soiling. Manufacturer's instructions for storage guidance. Ensure stock rotation, undertake regular check for wipes and packets. Consider the need to clean wipes, containers, packets, depending on risk of contamination of external internal surfaces. Ensure wipes are only used for their intended purpose according to local work department policies or guidance. Ensure all staff who will use wipes have received training on how and when to use them. So in conclusion, the presentation explored the role of nursing and nurses in provision and maintenance of clean environment. It highlights the importance of rule clarity of cleaning purposes, management of local services and standard, and the impact of patient and public perception when expected standards are not met. Highlights the importance of engaging specialist infection prevention team. Any question from the audience? أي سؤال يا أخوان؟ الشاشة واضحة عندكم يا أخوان؟ في أحد الزملاء يقول ما في شاشة. طيب يا أخوان، اللي الشاشة مو واضحة عنده معناته المشكلة عنده يا أخوان. طيب ممتاز. We will move to the next presentation. احنا تكلمنا امس عن البراين ديزيز باختصار، لكن حنتكلم اليوم بمزيد من التفصيل. And we will present a video about prion disease. Hopefully it will be helpful. Prions and its transmissibility, infectious agency. Prion present a unique challenge for decontamination because they can adsorb to a surface and present dramatic resistant to removal and activation. The risk of prion decontamination can be reduced by a standard precautions intrinsic in the infection prevention practices. Healthcare prevention professions must change mindset and expectations. The basic goal of decontamination is to render a surface or a stable surface for the handling or use or disposal. In most cases, the attention of decontamination is drawn to microbiological concern, in particular pathogens such as bacteria and viruses, and preventing their transmission. Decontamination should also include any chemical or biochemical risk that can pose safety concerns to patients. Prions, a term coined to 1980s to refer to proteinaceous infectious agents. They are known to be infectious and transmissible. They are known to be infectious, and they are proposed to be composed exclusively of protein. They are notable like any agent-specific nucleic acid, DNA or RNA. They present dramatic resistance to known decontamination process, including cleaning, disinfection, and sterilization process. Prion disease, TSC, are fatal degenerative brain disease of animal and humans. TSC, which represent transmissible spondylitis. Examples include Jacob disease, variant Jacob disease. The average rate worldwide is considered to be 1.4 in a million population worldwide. Diagnosis can only be truly confirmed by a brain biopsy and generally following patient death. A rate as high as 2.6 in a million has been reported in Austria and Switzerland, presumably due to more active surveillance diagnosis. Interestingly, the sheep prion disease, known as scrappy, is considered more prevalent. Prions are described as a proteinaceous infectious agent. Prion disease had been known for many years to be infectious and transmissible. During the progression of prion disease, the normal folded structural form is converted to an abnormal protease-resistant form. Proteins are made of a defined sequence of amino acids, but are folded into a particular structure to give the protein its unique structure and function. They are continually being made and broken down in cells. The misfolding of the prion protein is important. In that this form doesn't break down fully and can accumulate progressively and lead to cell death. Although a prion disease clearly plays an important role in these diseases, many other factors have been suggested to be involved in the conversion process and the disease process, and this includes various polysaccharides, lipids, DNA, and even other proteins. This unusual ability renders it capable of being transmitted from one subject to another with a particular medical consequences, not the least of which includes the use of human animal tissue. Prion disease transmission in human has been established from a contaminated meat or meat products, human tissue, and through reusable medical devices. Other tissues, even those with known or at high risk of TSE, have traditionally been considered to have low or even no risk of contamination or infectivity. Overall, WHO classified such risk as high, low, and no considered risk, IA, IB, and IC. Tissues like skin and heart in the IC category are not considered a risk and are expected to provide animal, if any, risk of disease transmission. In general, levels of detectable prion disease are considered higher in certain other tissues and vary in Jacob disease comparison to CGD, such as appendix, ileum, and rectum. At high risk tissues in human include brain, spinal cord, and spinal ganglia, with highly suspected tissue including the retina, optic nerves, and pituitary gland. Blood is an important consideration and has been confirmed as an infectious and variant Jacob disease, but is unknown with other human TSC. It has been known for some time that medical devices contaminated with prions can be transferred prion disease to recipient patients. The first known report was published in 1970s with Jacob disease transmission in 2 patients as a result of contact with contaminated intracerebral electrodes previously used in the brain of a person with the disease. These studies are further supported by experimental evidence that show disease transmission evidence and device service and contaminated tissues. In considering prion decontamination, there are a number of practical aspects that should be understood. The most important can be considered the test method that is used to evaluate an effective process method or product. Many antimicrobial methods have been defined for testing the effective decontamination process. These methods recommend the use of well-defined strains of microorganisms and a well-defined test methods. It is simple to process that contamination tissue should be inoculated into service and used for such testing. One such test has been proposed and used by a number of laboratories for decontamination investigation. The test essentially takes the brain from infected animal at the terminal stage of the prion disease, use it to inoculate a test surface, expose the contaminated surface to any decontamination process, and then introduce each individual wire into the brain of a susceptible animal. The animal are then incubated to the point of the end of their life unless they succumb to a prion disease or begin to die of neonatal causes. Effective methods will be indicated by premature death and can be confirmed to have died of prion disease by histological analysis. Effective methods can be similarly be confirmed by the absence of disease. The test can include a series of positive controls with samples of the original brain material prepared as homogeneous serially diluted. These positive controls can show a consistent rate of death in subject animals that varies based on the level of prion inoculation and incubation time. Therefore, higher levels of prions can lead to reasonably rapid death in susceptible animals. But as the initial contaminated material is diluted at the time at which animal appears to die get longer until a point is reached that no animal dies. But as initial contaminated materials is diluted, the time at which animal appears to die gets longer until a point is reached that no animal dies. Using these positive control, a level of log reduction can be estimated based on the lethal dose incubated time. These are long-term experiments with the most rapid being those described with hamster adapted scrappy model and even being typically 2 years incubation. First, the strain or source of prion material could play a significant role. Various strains of prions have been identified to date and continues to be isolated. Prions vary because of origin, incubation periods, clinical presentation, distribution in the brain, transmission between species, susceptibility to inactivation methods. There are other methods proposed to investigate prion decontamination. A rather simple but unfortunately unreliable method is the direct visualization of the effect. These assays include a standard scrubby cell assays and the protein misfolding cyclic amplification assay. They both utilize the ability to detect the rogue prion proteins by conversion of normal PRP in vitro. They have been particularly noted to allow for the lower level detection of prions in comparison to established in vivo methods. Other test methods criteria may also need to be considered, such as drying of grain homogeneity, the choice of surface and presence or absence of contaminating soil, overall the lack of fully understanding the true nature of infectious agent in prion disease limits the research into preventing transmission and the development of decontamination methods. The other point of note at this stage is the practical consideration of safety and efficacy requirements of decontamination process. A variety of prion decontamination methods have been investigated and even recommended for clinical use, but have limited practical application. High alkaline treatment will destroy most surgical devices, and steam sterilization is applicable only for high sensitive devices. Overall, any prion decontamination methods will be required to be reasonably safe for use. The method may also need to be effective against other microbial pathogens depending on its claim and use. Include heat, radiation, and filtration. This will include physical inactivation. There is a lack of any appreciable efficacy of radiation on prion infectivity. Investigations to date would suggest that radiation had little effect against prions under exposure conditions that would be rapidly effective against microorganisms. Overall, radiation did have an effect, but may have been hindered in penetration and antimicrobial effect due to interfering substances protective mechanisms. It is important to note that this observation may still support the lack of any associated nucleic acid with prion infectivity. There are limited number of studies on the effect of the other radiation sources such as microwave energy, which have some little to no effect. Heat is widely used and appreciated for its antimicrobial effects. Dry heat inactivation studies for prion have shown mixed results that may be due to differences in test methodology. But overall, dry heat can reduce prion infectivity in 80 up to 100 Celsius range over time. The concern is that low-level prion infectivity can be observed under these and even more aggressive conditions, such as 300 Celsius for an hour and even under insertion. Insertion is often cited as an effective method to remove prion infectivity, but again, presumably due to various protective and resistant mechanisms, may not always be completely effective. It is also important to note that these experiments are typically conducted with whole brain materials, which may have significance in laboratory practice, but has less applicability in the device decontamination. More detailed studies have been conducted with heat disinfection and sterilization. First, heating and boiling for disinfection purposes appears to have no impact on reducing prion infectivity. Higher temperature are much more efficient One of the most widely recommended methods for reducing the risk of prion decontamination on device surfaces is steam sterilization at 134 Celsius for 18 minutes. Again, the data to support this recommendation is mixed and can be partially considered a factor of the test methods employed. Again, the data to support this recommendation is mixed and can be rapidly considered a factor of the test methods employed. The majority of test methods used prior to 1999 did not consider device decontamination and are based on suspension studies. Overall, the results are variable from study to study. It is important to note that most of these experiments had been conducted in laboratory sterilizers. The full steam sterilization cycle conditions were not described. Information regarding the correct operation calibration of the sterilizer cannot be verified. Despite these concerns, some important conclusions can be made. Steam sterilization is an effective method to reduce prion infectivity. Steam sterilization generally requires longer exposure time than those typically used for microbial inactivation. The true impact of higher temperature is more debatable in that there is evidence of cycle at both 121 and 134 Celsius being effective at 1 hour exposure conditions. In a more recent studies and discussion of steam sterilization data, there is even some evidence to suggest that higher temperature may even be less effective. An interesting conclusion from one of these studies was the effect of hydration on exposure to the steam process under test. When test surfaces are exposed to dry to 134 Celsius for 18 minutes, infectivity was significantly reduced but not completed. But when a similar set of test surfaces are exposed in water to the same sterilization cycle, complete reduction was observed. It is clear from these studies that steam may not have actually contacted the test surfaces as they were immersed, but the prion activation effect may be proposed to be due to slower heating over the exposure time. This highlights the difference between biocidal effects that are known to be detrimental to microorganisms, but not necessarily against prions. Another unexpected result can be concluded from these studies, which has been observed in other experiments. Cleaning of surface prior to steam sterilization can dramatically impact prion inactivation. Washing with water alone had little effect in reducing infectivity from contaminated surfaces, which is not surprising considering the hydrophobic nature of brain material and the prion protein structure. When followed by extended steam exposure, the reduction was significant, but not completely effective. Overall, it may be concluded from these studies that cleaning cannot be expected to reduce the risk of prion infectivity and may in some cases reduce the effect of steam. It will vary depending on the individuals. Further physical methods of reducing prion infectivity is biofiltration methods. It is based on the affinity of prions to specific filter type processes. Such methods have a little impact on device decontamination. But have been particularly highlighted in the development of process for reducing the risk with the human animal tissues, such as blood or plasma. Alternative physical approach is the specific type of materials or coating that prevent the attachment of hydrophobic proteins on surfaces. Further investigation will be required. Review on chemical effect on prion decontamination can often be misleading. Most of the initial studies using various types of chemical did not reflect surface contamination or how many of these are actually used for disinfection and or sterilization process. These effects can dramatically affect the antimicrobial properties of biocides and are often underestimated. It may be safely concluded that such effects could also affect the prion infectivity positively and negatively. Other example is that some chemicals may have shown partial activity but are often listed as being ineffective as they were not completely effective in a given published study. It is likely that many of widely used biocides should be investigated in closer detail to understand their true impact on prions. An example of this is with hydrogen peroxide, which in initial experiment was considered to have little impact on reducing prion infectivity. With subsequent experiment, it has been shown that under a specific liquid and in gas phase conditions, that hydrogen peroxide was particularly efficient against prions, and reduction in prion infectivity can only be concluded based on direct experimentation with that product or process. Prion have been shown to be relatively resistant to effect of acids but sensitive to alkali. Acid SDS-based formulation have recently been shown to have a dramatic effect on reducing prion infectivity. There is much evidence for the support of strong alkali against prion. Alkali have also been shown to degrade the prion proteins in vitro. Despite this result, there remain mixed reports in the literature regarding the full reduction of infectivity. This had led to recommendation of combined alkali and steam treatment as a decontamination method. Many recent studies on surface decontamination have reported particularly effective prion decontamination with alkaline-based detergent formulation under various test conditions. Overall, these studies propose that alkaline-based detergent can be safely used to reduce the risk of prion decontamination, but that these will vary depending on product formulation. It was interesting to note that variant Jacob disease strains appear to be more sensitive to alkali inactivation than scrubby strains. This contrasts to some steam studies. Many biocides considered to have a cross-linking mechanism of action are not considered to have any benefit reducing the risk of prion contamination. Cross-linking would appear to be counterintuitive due to the potential fixing effect of protein into surfaces. Many reports would show little impact on prion infectivity. Despite these reports, many experiments have highlighted that some of these biocides could play an unexpected role in contamination. A notable class of chemical that has shown particularly promising result is the halogen and other oxidizing agents. The key example in this case is chlorine. High concentration of active chlorine over time have been shown to be effective against multiple strains of prion, including surface decontamination. Lower concentration of chlorine in formulation under controlled temperature conditions have also been shown to be effective. Improve the negative impact on surfaces of such chlorine concentration. Such methods are widely used in laboratories to wipe down surfaces. They are considered to be at low risk of contamination. Although prions are not traditional microorganisms, they are transmissible and unusually resistant to decontamination. It has already been highlighted both clinically and experimentally that prions can pose patient risk if present even at low levels on device surfaces. The reduction of the potential risk of prion contamination should be considered as part of necessary standard precautions that we expect for device decontamination. Currently, scientific knowledge is lacking. It is challenging to consider if prions are unique in their biochemistry and effectivity. Any question, يا إخوان? أي سؤال? We'll have a video presentation. الصوت واضح يا إخوان والصورة واضحة لو سمحتوا. صوت وصورة واضح يا إخوان. طيب في أي سؤال يا إخوان؟ Any question from the audience please? طيب يعطيكم العافية يا إخوان. We'll move to a video speak about prion disease. I think it is important to see it again. والله استاذ محمد التركي ما اقدر اجاوبك بس الاخوان ان شاء الله يجاوبونك لان هذا التكنيكال بارت صراحه ما اقدر اعرف الجواب يعني. بس اتوقع ما اعرف ما اقدر اجاوبك.
I've been asked to talk about diagnosis and treatment, and what I was going to do was make some general points about diagnosis and review recent diagnostic developments, make some general points about treatment and talk about treatment possibilities, and then at the end give you a guide to maybe what you should ask experts who try to sell you something. So some general points about diagnosis. Well, the diagnostic process, if you present to a neurologist with one of these diseases, is, first of all, that the presentation is very non-specific. People who present with sporadic CJD can present ways very similar to many other diseases. So obviously the neurologist has to think of the possibility, and earlier on we had a bit of discussion about that. Having thought about the possibility, there will be a range of possibilities, and the neurologist has to exclude other possibilities. And then finally, having excluded those other possibilities, try to seek confirmation from tests. I heard the phrase diagnosis of exclusion in the meeting that we had beforehand. In my view, that's something that neurologists in general strongly disapprove of. Every diagnosis is actually a positive diagnosis. It's one of inclusion. The exclusion is because you have a differential diagnosis, a set of diagnoses, and you have to exclude some of them, but then confirm the ones that remain. And as we discussed as well, sometimes the passage of time is helpful, and that is very difficult. I understand that for patients and their relatives, but the way that the illness evolves over time may be critically important in the diagnosis. Also say that some tests that are done have two roles. One role is to exclude other diseases, and another role is to act as a confirmation. So in the initial stages of these diseases, a brain MRI and a lumbar puncture to look at the spinal fluid is not specifically done to find abnormalities of CJD, to confirm it, but because these are very important ways of excluding other more common and maybe treatable illnesses. Abnormalities on brain MRI and CSF may be very important in that respect. If we turn to confirmatory tests, and I'm going over a bit of what's been said already, essentially one can have non-specific tests. They're not related to the basic disease mechanism, but by chance they happen to be very useful. On the other hand, they're essentially specific tests that are related to the basic disease mechanism. I'm not going to label this point, but the essentially non-specific tests have traditionally been EEG, the brain MRI, and CSF 1433. And while I wouldn't deny the utility of these investigations in certain specific clinical contexts, the most important thing is that the abnormalities seen in these tests can be seen in other diseases. And therefore, their utility in confirming CJD depends very much on the clinical context, not simply on the abnormality of the test. So if we turn to basic disease mechanisms, there are two really. One has been around for quite a long time, and that is the detection of a genetic mutation, a genetic prion disease. So if you have something that looks like a prion disease, and particularly if you've got a family history of prion disease, finding the appropriate mutation on a genetic test is very, very specific, and you really can't argue with that. However, outside of genetic disease, the essential specific test all relates to PRP-SC, this grade P abnormal form, as you heard from Brian. And this is the hallmark of the disease, the deposition and presence of this abnormal prion protein. So if you find it, it should be a very specific finding. And effectively, most PRP-SC, this abnormal prion protein, is in the brain. And therefore, if you want to confirm the diagnosis, you have to look at the brain, and therefore you may do a brain biopsy in life, which is not a simple undertaking and is rarely done, or you do it at autopsy, in which case the diagnosis is quite late. Now, you could look for PRP-SC elsewhere in the body, and as you've heard already, traditionally, variant CJD is known to affect other tissues in the body, and in particular tissues like the tonsil. So tonsil biopsy has been a disease-specific test in variant CJD for some time. So I'm now going to turn to recent diagnostic developments. And they can be classed in two groups, really. One is improved detection of PRP-SC, and the second is simpler methods to obtain neural tissue. So if we look at improved detection, it is a fact that PRP-SC can be found outside of the brain in sporadic CJD and other forms of CJD, not only variant CJD, but it's usually present at very low levels. And these levels are so low that our ordinary methods of detection are not good enough to detect them. However, if you could make these levels higher by amplifying them, then maybe they could become detectable. And Brian's touched on this already. Amplification, you might have a sample with a small amount of PRP-SC, which is undetectable by normal methods. You amplify it until there's enough there to detect. And as you've also heard, this amplification is essentially a hijacking of the autocatalytic conversion of prion protein. PRP-C, when it meets PRP-SC, is converted into more PRP-SC. This is a disease mechanism, but it can be hijacked in the laboratory to amplify PRP-SC from people with illness. Again, I'm truncating this a bit, but there are two broad methods that you can hear of, PMCA and RT-QuIC. There are some refinements of these methods which are sometimes given different names, but these are the two core methods. So if you're going to use these methods, what tissues could you use them on? Well, obviously you want more accessible tissues than brain and the whole. So spinal fluid obtained at lumbar puncture, blood, urine, and indeed skin have all been looked at. Certainly, the key thing in use at the moment is the RT-QuIC in spinal fluid in sporadic CJD. And you've heard a bit about this already, and it's probably the single biggest diagnostic advance that I've seen in the diagnosis of sporadic CJD. Blood, there are tests available which are pretty good for variant CJD, although interestingly not for sporadic CJD, and also urine tests which are pretty good for variant CJD, but not sporadic CJD. And as you heard from Brian, there are currently no living cases of variant CJD in the world, so these are not particularly in use at present. And then there's the interesting aspect of finding PRP-SC in the skin, and this has been done, as far as I'm aware, in both sporadic and variant CJD, and you will hear a bit about this later in the conference. So what about simpler methods to obtain neural tissue? And by that I mean simpler than looking at the brain. Well, one method, which again you'll hear about at this conference, is that in order to smell, things have to go up your nose, and then they meet certain specialized neurons and nerve cells which deal with smell. And these are effectively outgrowths of the brain. So if you put a brush up into the nose, you can indeed obtain certain nerve cells from the top of the nose, actual neural tissue. And then if you use amplification methods on these bits of nerve tissue, you may be able to detect PRP-SC. So this is a relatively new and interesting development which you will hear more about. I think that I would like to make one very important point, however, that it doesn't matter how technically good any test is. They always need to be used in an appropriate person at an appropriate time. They're always only part of the clinical process. I thought I'd mention in passing that you may all be thinking, well, wait a minute, there's PRP-SC in blood or urine or skin, we can detect it. Is it a risk? Well, I'm going to make a few statements, but not too much detail. First of all, detecting abnormal PRP is not necessarily detecting infectivity. You cannot equate abnormal PRP-SC with infectivity in a simple manner. And I think it's worthwhile mentioning that there's normal prion protein that we're all busily making at this moment in our body. There's an abnormal prion protein which occurs in different forms, and then there's the infectious agent, the prion, and these things are not the same. And I think sometimes people talk about them in rather confusing, overlapping ways, but you need to keep them separate in your mind. And infectivity in experiments showing that you can indeed transmit diseases in the laboratory is not necessarily natural infection risk. In real-world human infection, there are all sorts of complications, like the actual dose of the infectious matter, the route by which it's transmitted to the human person, and also the person's makeup, genetic and otherwise. And I think it's worth particularly emphasizing that there is no evidence, despite a lot of study over a long time, of ordinary infection with human prion diseases, even with intimate human contact. I'm going to turn to treatment and make some general comments about treatment. Well, obviously, everyone wants successful treatment, and it's, well, straightforward, isn't it? You give a treatment and see whether they get better or not. And I'm not going to argue with that general statement. I thought I ought to at least qualify it. First of all, there are two treatment situations, one in which you treat somebody who's clinically ill, and the other is in which you treat somebody who's not ill, but to prevent their becoming ill. And of course, in prion disease, the main feature here in prevention will be people who carry one of these mutations, as you heard from Brian, and they are therefore at risk of developing disease in the future, and you might want to prevent it. But I think it's worth noting that a treatment that's affecting one role, such as clinical illness or prevention, may not be effective in the other role. They don't necessarily always belong together. So if you have a disease, you then develop symptoms. And if you give treatment, the treatment may indeed affect the symptoms, or it may affect the disease process, or both. And what we're clearly interested in the end is a treatment that the disease process actually stops the disease process happening, rather than simply treats the symptoms. However, it's not always easy to tell the difference, and I'll touch upon that again in a minute. You may give a treatment and see some kind of improvement, but actually what you're doing is simply treating the symptoms, not the disease. If you do affect the disease process, you could, of course, affect a cure or a very major effect on the illness, and that's, of course, what everyone wants. But you might have a minor effect on the disease process, and everyone will say, well, okay, that's interesting. But one of the difficulties is that detecting a cure or a major effect is easy, but detecting a minor effect may be potentially difficult. And you might add, okay, well, it doesn't matter if it's so minor, it's difficult to detect, who cares? Well, the answer is because if you do have a minor effect, it may tell you that the treatment that you're using is not the answer, but it's on the right track. And if you look at the history of cancer treatment, that's pretty much what has happened. People had treatments which had minor effects. These were noted, and then these treatments were refined to the point whereby there may be major or even curative effects. Of course, when you give someone a treatment, you can have benefit and you can have harm. These two are inseparable, at least to most allopaths like me. Homeopaths do believe that you can separate them, but I think personally that's an illusion. So if you have side effects, you have harm, they may have different significance. If you have a clinical illness which is going to progress and kill you, you might put up with quite significant side effects. And indeed, in cancer treatment, people do that. On the other hand, if you're perfectly well, and you may or may not develop some disease in the future, and you're going to be given something to prevent that disease, you probably want it to have rather minimal side effects. And of course, one potential harm of successful treatment, which is discussed in this area, is if you can have a treatment which halts the disease process, but the brain is left irreparably damaged and can't be repaired, maybe that's in some sense a harmful treatment. Maybe that's something that you don't actually really want to do. So with those comments, I'm going to ask, okay, I've got a new treatment which I'm proposing to use. How do I evaluate it? How do I actually find out if it's any good? Well, you could do it in the laboratory at the level of protein molecules. So you look at the abnormal form of prion protein and its chemistry, you put the treatment in the test tube and you see what happens. And that's okay, but that's not a biological situation. So then you go to cells and you grow cells in dishes and you infect them and you have a look and see how your treatment works in the context of a functioning living cell. But that's okay. You then must say, well, does it work in whole living animals? And so you turn to animal experiments. And in this area, it's usually rodents who tend to suffer. And a lot of the experiments are indeed rodent experiments. But this is the typical animal experimental methodology. You take a set of rodents and you inoculate them with infection, as is shown by the red star. And you take another set of rodents and you inoculate them with infection and also a treatment, which is denoted by the green cross. And then you follow things up over time and you look at the number of animals that become ill. You look at the incubation period, the time it takes for them to become ill, and then you kill the mice and have a look at their brains and see how bad the pathology is. And clearly, if the number that become ill in the treatment group is fewer, and the incubation period is longer, and the pathology is less, then you have a treatment which is actually doing something. But there are some potential problems with this. First of all, this is an infection model. And indeed, many of the diseases like sporadic CJD are not really infections. And of course, you're doing the infection by a specific route of uncertain human significance. So most of these experiments are done in ways in which to ensure that you get a result, which means, for example, inoculating the rodents' brains with infectious material. And the question is, how does that really relate to humans? You also have to choose a particular disease to study, and many of these experiments choose diseases like scrapie, as you've heard about from sheep and goats, or other forms of disease. And the question is, are the results from one disease really transferable to another disease? And most of these experiments are done by giving the infection and the treatment either at the same time or pretty near the same time. In other words, you're looking at treatments in rodents that are either preventative or in the very early stages of disease. So does this really transfer easily onto humans, who by the time they're diagnosed may have quite late disease? And finally, far be it from me to point this out, but rodents aren't humans. And although they tell you all the time that these mice have been transgenically manipulated, so they've now got human genes, they're still not human beings. So as a clinician, for me, treating humans is the real aim. And the most relevant and important experiment you can do is an experiment involving humans. Unfortunately, this is potentially the most difficult. Organizing a human trial can contain a lot more difficulties than simply imprisoning a few mice in cages in laboratories. And I thought I'd just take you through some of this. First of all, there's what's called the problem of measurement. You can kill the mice and look at their brains. That's easy enough to do. But with humans, it's more difficult. So what you tend to do is rely on two things. One is directly observe clinical. So you see what someone's like and what they can do. You then treat them and then see what they're like afterwards. And that's to some degree okay. And then the specific measurable disease activity markers. So for example, in HIV and AIDS, there are tests you can do counting cells in blood samples, which tell you pretty much how they're doing. When we look at directly observed clinical improvement, one of the problems, and it's not related only to CJD, this with multiple sclerosis and Parkinson's disease and other neurological entities like stroke, the objective measurement of severe and multimodal neurological disability is fraught with all sorts of difficulties that you may not imagine until you come and try to do it. People have, of course, suggested, well, let's cut away this and just take some very simple measure, like the time it takes to reach a certain clinical point. So if people with CJD stop walking at some point, let's just measure the time to when they stop walking, because that's fairly objective. Or if we're going to be really fairly crude about it, the time it takes for people to die, actually the length of the illness. And these measures are, of course, simple, but they will miss minor improvements, and they have other difficulties, which I'll mention in a minute. So if we had some specific measurable disease activity marker, it would be great. But at the moment, as far as I know, we don't have any of these in prion disease. There's no equivalent to taking a blood sample and measuring certain kind of lymphocyte activity that you see in HIV. So the next problem is the problem of variability. And you have this triangle: the disease affects the individual, the treatment affects the individual, and the treatment affects the disease. And there's variability here. The way in which the disease affects people is variable, and the way in which the treatment affects people is variable. If we just look simply, as you've heard from Brian already, the different disease types are variable. So sporadic CJD, for example, and variant CJD and genetic CJD have quite different clinical progressions and symptoms. So if you do any kind of study, you either have to choose one disease type or make sure that you allow for the variations of these disease types in your study. If we just say, okay, sporadic CJD is by far and away the commonest form, let's treat that. The difficulty here, as you've also heard from Brian, is variability. So even if we took a really simple experiment and said, let's look at the duration of the disease, the time it takes for people to die with sporadic CJD, Well, what we found, and this is a study done by Maurizio Boccari and colleagues in Europe, is that these graphs here, as you go along the bottom axis outwards, time is increasing, and as you go down the vertical axis, the number of people alive are decreasing. And you can see the shape of the graph as people with the illness succumb. And first of all, females succumb slower to males. Secondly, the age of onset is quite important. The older you are, the more rapidly the disease progresses, and the younger you are, the slower it progresses. You heard from Brian about 129, and this has quite a profound effect on the rapidity of disease progression, as indeed does the prion protein type. So if you're going to study sporadic CJD, you might find that somebody in your treatment group lives a lot longer than somebody who's not in your treatment group. But it may be because they're female, young, of a certain genotype and a certain protein type, and nothing to do with the treatment at all. And you have to allow for that in your study design. There's then the problem of bias. So basically, you can see benefit that isn't there. You attribute spontaneous changes to treatment erroneously. And you may do this for all sorts of reasons. One is that you believe in your treatment, and another is that you clearly wish to see improvement. This is quite an important factor in detecting particularly minor improvement. There's the problem of what are called confounding factors, and these are improvements that are not related directly to the drug. So there are lots of examples of this in human treatment trials, where people in the drug trial get better general care than they would have done, more regular follow-up than they would have done if they hadn't been in the trial, and therefore they tend to do better, but it's not to do with the actual treatment, it's to do with these side issues. What's the scientific solution to this? Well, first of all, have a trial with large numbers in it, so you even out all these bits of variability. You have a comparative arm, a group that's treated with something and a group that isn't treated with it, so you can compare them. You randomize people to these groups, so you don't have any internal bias as to putting, say, females in one group and males in another. And you're blinded, so that the person assessing the effects of the treatment does not know whether the person's on treatment or not. And this is the standard scientific solution, the large-scale randomized controlled trial. So if we're to look at this, trials with large numbers need large numbers. And as you've heard, this is a relatively rare disease. So in my view, if you have a treatment trial, you should, if possible, try to have one with international collaboration to include reasonable numbers of patients. Secondly, you should have either placebo-controlled or comparative groups and randomize them, but there are differences of opinion about this. Would you accept to go into a trial knowing that you might be randomly given a completely inactive treatment in a disease which is inevitably progressive and fatal? And there are lots of differences of opinion on this, but I have to say, in my view, the weight of history of treatment trials in humans, the problem of detection of minor change, and the possibility that an unknown treatment may be harmful. It's not always a question of beneficial, working or not working. It could be harmful, means that in general, you really should have placebo control and randomization if you can. And what about blinding? Well, there's differences of opinion on this also, but I think actually there's a lot of evidence and history that assessment in treatment trials should be blinded. And I'm not talking only about human trials, I'm talking about rodent trials as well. One of the things that laboratory people have been particularly bad at is blinding. Just as a historical comment, since 1971, there have been over 40 reports at attempted treatments in CJD, involving at least 15 different drugs. And many of these reports were bordering on useless. They contained small numbers with very poor methodological design and very few randomized controlled trials. And just as an important aside to this, a bad experiment may, of course, exclude something that is useful. It doesn't necessarily always end up with a drug that's actually useless being regarded as useful. It could be that it mistakes a drug that is useful for being useless. So good design is important. And I have to say that in recent times, there have been the emergence of much better design trials in CJD. So briefly, treatment possibilities. this is a very schematic form, but PRPC becomes PRPSC, but it goes through certain intermediate forms on the way. And this basic protein pathology somehow or other causes neuronal death. But actually the relationship between these protein abnormality and the neuronal death is not terribly clear. So you've heard that PRPC is essential for this disease, so removing PRPC might be a good idea. You've heard that PRPSC is obviously this abnormal folded protein could in some way be harmful, so tackling that may be important. But I think much more important probably is this, that the intermediate forms between PRPC and PPSC are probably more dangerous, and if we're going to target therapies, it's probably at this level that people should be looking. And finally, in the end, neuronal death is what counts. The reason that people develop symptoms and become ill and die is because brain cells, neurons die. And therefore, trying to tackle this problem of neuronal death might be really important. But I have to say that at the moment, we don't know very much about the mechanisms here. But you will hear at this meeting a little bit about some of the possible mechanisms and how they might be related to treatments. PRPC, one thing is to have an antibody that destroys PRPC, and you'll hear something about that, I would imagine, from John Collins at the meeting. And you will also hear a bit more about halting the process of neuronal death. One thing I would say in passing is that what really seems to be the key effect of these diseases is not the disease of the neuron itself as such, but the disease of the connection between the neurons. So these electrically active neuronal cells communicate with each other at junctions called synapses. And it seems that the earliest changes occur here before the neurons themselves become ill and die. And the experimental evidence, without going into any detail, is that these early synaptic changes are actually potentially reversible. So actually knowing when this very early phase takes place is a much more therapeutically promising area than waiting till neurons themselves die. So early treatment is usually better, but early treatment requires early diagnosis. So these two things really link together. Well, you can look at prevention in genetic disease, but in terms of sporadic disease, the real question I think is, can we diagnose this sort of disease early enough to stop the disease before neurons die and people become severely disabled? I should just add that on the genetic side, there is a long-term Italian study currently progressing where doxycycline, an antibiotic, is being given to family members who are currently not ill, and they're being followed up to see if the disease develops in the subsequent years. But this is a quite remarkable study, not least because a lot of time have to pass by, and the full results of this experiment may exceed the professional or indeed the biological survival of the actual people doing the trial. So I'm going to finish with a bit of a quick guide to listening to experts. Diagnosis. If people try to sell you a diagnostic test, you want to know how sensitive it is. That is, how likely is the test to be positive if you have CJD? And without going into details, this sensitivity is a function related to the test performance and the disease, those two things. On the other hand, specificity, how likely is a positive test due to CJD and not something else? That's essentially related to the test, but the context in which it's done. So sometimes people quote specificities of a diagnostic test, but they're talking about an evaluation of that test in a very specific set of circumstances. It's not necessarily transferable to general clinical practice. So just bear in mind, test results can be false positives and they can be false negatives. Treatment, well, the questions you should actually ask about any experimental model is, what is the likely human relevance of this? Is this a test tube, cell culture, animal experiment? What effects were measured? What was the timing of the treatment in relation to the time of infection? And was randomization and blinding used in animal experiments? They really should be, just as it is in human disease. The likely human relevance of the type of disease they've studied, If they've given a drug to animals, how could it be given to humans? The mode of administration may not be suitable for humans. And should it be studied in some form of randomized controlled trial? If it's a human treatment trial, you want to ask about what measurements they did, how they dealt with the problems of measurement, their variability in humans in the trial, and aspects of bias and confounding factors. How many people did they treat? Was it controlled? Were the two groups matched properly? Were they randomized to the two groups? Was the assessment blinded? What measurements were taken? And were those measurements meaningful? You'll sometimes get treatment trials which show some sort of measurement, a change of 1 point on a scale of measurement that's actually statistically significant. But when you look at what that actually means, it means very little indeed. You may think that I've been pessimistic or overcritical, but I think you need to understand the complexities, and hope should always be tempered by realism. But as I've said earlier on, care is necessary because useless treatments could thought to be useful, but on the other hand, useful treatments could mistakenly be thought to be useless. And so with that, I will finish with a slide from where I come from that has no.
Okay, we will continue our next presentation. It's about dental care decontamination. Providers overview the issue of microbial biofilm development in dental unit water lines and microbial biofilm development, microbial contamination of output water. Reviews the underlying cause of DUWL biofilm contamination. Reviews evidence of cross-infection and other disease risk associated with exposure to contaminated DUWL output water. ايوه التحضير ضروري كل يوم لازم يا اخوان معلش يعني بس لازم التحضير كل يوم. Reviews evidence of cross-infection and other disease risk associated with exposure to contaminated DUWL water output water. The various approach that have been investigated to damage DUWL biofilm and their strength and weakness are then discussed. Examine the development of centralized and automated system for managing dental unit water line. Review associated water distribution network in the dental hospital setting. By early 1990s, 19th century, the basic design of dental chair was established. Over a decade of 20th century, the function of dental chair changed significantly, changed from an item of furniture that was intended solely to provide physical support for the patient while permitting easy access to oral cavity by dentists to a complex, compact appliance comprising a modern dental chair.
This short video has
Development of the modern dental chair was driven primarily by the increased sophistication of dental techniques and procedures, advances in dental instruments, Instrumentation, especially dental handpiece equipped with high-speed monitor, air-driven and electric motors, the availability of new materials and metal alloys. Modern dental chairs are available in a wide range of styles, configuration, and are less classed as medical devices according to the European Union Medical Devices Directive. Dental unit waterline many operation of modern dental chair unit are dependent on the use of water as irrigation and coolant and for rinsing. Cooling of dental care unit. Instruments and irrigation of tooth services during dental instruments is vital, as significant heat can be generated during dental instrument operation that could have a detrimental effect on teeth and surrounding tissue. Dental units can have two other water outlet, including a cup filler outlet that provide water for patients for oral rinsing. Dental units can have two other water dental outlets, including cup fillers and bowl rinse outlet used for rinsing and dental units spot and bowl and capsulators. Dental units provide water to dental instruments and air water syringes by network of dental unit waterline. Each dental unit contains several meters of interconnected DUWL tubing, generally composed of polyurethane. This material is highly durable and pliant and can withstand the repeated movement experienced by tubing during dental handpiece ultrasonic scaler. Dental instruments connected to dental unit are attached by coupling connectors fixed to flexible hoses that enclose DUWL, an air line, and electrical supply line, the latter to power micromotor and dental instruments. Coupling facilitates quick detachment of instruments following use to permit their cleaning, disinfection, and sterilization prior to reuse. Complex medical devices often provide opportunities for colonization of environmental eventually resulting in formation of dense biofilm that cause DW output water to be heavily contaminated with microorganisms, particularly with bacteria. It has been shown that biofilm begins to develop within DWL of new dental units within hours of connection to maintain supply. Today, a significant number of dental practitioners still encounter difficulties in dealing with this problem on a daily basis. The underlying reason why DWL are vulnerable to biofilm formation are varied. Several factors contribute to this phenomenon. The most important contributors factors are the narrow bore of DUWL, water stagnation within DWL. Other factors include anti-retraction device malfunction, heating of DWL water, contamination of dental unit, water reservoirs, bottle, dental unit supply water quality. Water flow in narrow bore DWL tubing is laminar. Laminar flow generally occurs in small pipes or tubing and low flow rates. This means that water molecules flow through the tubing in straight lines in numerous layers. Consequently, a thin stationary layer of water termed the hydrodynamic boundaries layer exists at the margin. Furthermore, DWL exhibit a high surface of volume ratio. Water flow in narrow bore DWL tubing is laminar. Laminar flow generally occurs in small pipes or tubing and low flow rates. There is a resistance between water molecule and the walls of tubing that oppose the flow. Consequently, a thin stationary layer of water termed the hydrodynamic boundary. Furthermore, DWL exhibit a high surface to volume ratio. The surface area of lumen walls is large relative to volume of water that flows through the tubes. When a dental chair unit is installed and connected to water supply, inorganic and organic chemicals from the supply water are slow deposited in the internal walls of DWL, forming coating termed conditioning pellicle. Bacteria, and to a much lesser extent other microorganisms, present a DWL supply water fasten themselves to the conditioning pellicle via weak intermolecular interaction, termed van der Waals forces. Many environmental bacteria are adept at secreting exopolysaccharides. However, as a consequence of laminar flow conditions, biofilms that form DWL tend to be irregular or patchy in nature and contain cell aggregates intermingled heterogeneously by interstitial void or pores through which water flows. The biofilm canals form a primitive circulatory network to distribute nutrients, dissolved oxygen, and metabolic products. As many environmental bacteria are motile, the release of lactonic organism from the biofilm and DWL results in the movement of microorganisms. DWL output water is also realized by several dynamic dental instruments, including conventional and high-speed handpiece. These bioaerosol can persist in the air and dental clinic for at least an hour before settling out. The presence of biofilm in DWL functions as a reserve supply of microorganisms for ongoing contamination of output water. Unfortunately, DWL biofilm are universal feature in dental units and less effective control measures are employed. The majority of dental chairs are probably only in use for a maximum 8 up to 10 hours per day, 5 days per week. Even then, dynamic instruments use this water supply instrument used and this water flow through DWL only occur for probably 10 up to 15 minutes per hour. Furthermore, not all dental instruments connected to DWL and specific dental units are used at the same rate. Extended water stagnation encourages the gross proliferation and biofilm within DWL and is a significant contributory factor to heavily contaminated DWL output water. The most significant effect, anti-retraction malfunction, is an increase in the diversity of microorganisms. The retraction of human viruses is probably of less significance as these cannot replicate outside the human host cells. Dental instruments and dental unit instruments coupling hoses containing anti-retraction devices should be subject to regular maintenance and efficacy testing to reduce the occurrence of anti-retraction device malfunction. Integrated water heater that enable DWL water output water to provide at higher than ambient temperature. Clearly, dental units should not be fitted with water heaters. However, even in the absence of water heaters, the temperature of water DWL can increase significantly during daily dental unit use, possibly due to heat gain from the vivo. Dental units not connected to a main water supply use independent water reservoirs or bottles to supply water to DWL. The reservoirs are filled by hand with water, but can readily be contaminated with the skin cells harboring bacteria such as Staphylococcus from dental staff. This adds further human flora into DWL. Furthermore, biofilm can form an internal surfaces of reservoir bottles. Reservoir bottles should be regularly and meticulously cleaned. The microbiological and chemical quality of water supplied to DWL has a direct influence in biofilm formation within DWL. The presence of accumulation of hard water minerals in DWL increase. Deposition of hard water minerals may also impact the operation of anti-retraction devices. Water supplied to DWL from water storage tanks filled with potable quality mains water tend to contain higher levels of bacteria than potable water due to the sediment and the presence of biofilm in tank surfaces. Water stagnation is also an issue in water storage tanks. الصوت واضح يا اخوان؟ الصوت واضح يا اخوان؟ طيب شكرا. The physical condition of water distribution network components including pipes, tanks, valves, pumps, In dental units that use bottled reservoirs, the quality of water supplied to DWL is affected by the quality of source water and the physical condition and cleanness of the reservoir bottles. It is also affected by how long prior to use distilled water is stored and under condition these containers are maintained. These containers are also prone to contamination with bacteria via skin, squamous cell shed from dental staff. The majority of microorganisms present in DW consist of environmental bacteria, predominantly gram-negative anaerobic heterophobic species. Most of these environmental bacteria are non-pathogenic, although some have been identified. The diversity of environmental bacteria species present in DWL may be different in separate geographic locations. A range of fungi, yeast, protozoa, and amoeba has also been identified in DWL. لا يا اخوان، التحضير ما تطلع من الزوم، تبقى بالزوم لو سمحت بالله. اعمل تحضير بس علشان معلوماتك تتطابق مع معلومات الزوم. فاذا طلعت من الزوم ارجع مره ثانيه بالله. يعني التحضير لا يعني انك تخرج من الزوم، لازم 80% تكون حاضر في الزوم، يعني حتى وقت الصلاه لا تطلع من الزوم، خلي الزوم شغال. The majority of dental treatments are undertaken on the outpatient basis and thus patients are not followed up for post-treatment infections. It is therefore very difficult to establish a cause and effect association between exposure of the DWL output and water and subsequent infection because patients are exposed to a wide variety of potential infectious organisms during their daily activities. The composition of polysaccharide chain varies considerably and thus different species of bacteria can yield a unique endotoxin. In contrast, sterile water of irrigation has permitted endotoxin limit of 2.25 endotoxin units per ml in the USA. The presence of endotoxin and DWL water might trigger the release of pro-inflammatory cytokines in gingival tissue during oral surgery and have an adverse effect on healing. لا، بالنسبه اللي يطلع من الزوم بالخطا ويرجع، يعني هل يحضر مره ثانيه او لا؟ ما اقدر اجاوبكم، الزملاء حيجاوبوكم بعد شوي من الاداره. The EU potable water standard do not specify an upper limit in heterophobic bacterial density, the most commonly isolated and abundant bacteria in DW water. Filters can efficiently reduce bacterial density in DWL output water. However, they have no effect on biofilm present in DWL. Regular flushing of DWL with clean water is effective. In general, residual DWL treatment agents are more effective than agents used intermittently at eradicating DWL biofilm and maintaining good quality output water. Potential adverse effects of DWL treatment agents on dental unit components, dental instrument, dental restorative material, and environment are an important consideration. Another study reported problems associated with sterile ultra periodic use alkaline peroxidase disinfection. Previous studies have shown that some DOL treatment agents tested in working dental units are ineffective or only partially effective at removing DOL film. Pre-treatment of supply water usually involve filtration of specific kinds of filter. Sediment filters remove suspended solid particulate contaminants. The precise configuration of filter required to pre-treat supply water will depend on the characteristics of supply. All types of water filter unit require periodic maintenance and disinfection. Contaminated wash basin taps and outlet water are well recognized. Contaminating microorganisms may originate from biofilm and sediment in supply water, storage tanks, and other water distribution network components. So we have to consider dentists and allied healthcare professionals should adopt ADA and CDC recommended standard for the DUWL. All DUWL needs to be disinfected regularly and periodically using effective chemical treatment. The development of dental units with integrated and semi-automated DWL cleaning. يا اخوان الرابط على اللي بيسالوا في الكويستشن اند انسر الرابط موجود في الشات بوكس. في الشات بوكس الرابط موجود يا اخوان. رابط التحضير. Providing a consistent quality water supply, this approach automatically minimizes biofilm throughout the water distribution network, and DWL providing a good quality output water simultaneously from many dental units. Automated control of DWL supply and output, water quality, and individual dental units, and in the many dental units used in dental hospitals is the key to providing a long-term solution to DWL biofilm contamination. any question يا اخوان؟ اي سؤال قبل ما نعطيكم فيديو في نفس الموضوع؟ any question؟ لا رابط الحضور موجود يا اخوان فوق. هي المحاضرات ان شاء الله PDF حنعطيكم اياها كلها ان شاء الله. العفو العفو. طيب we'll provide a video it's almost speaking about the same subject. Hopefully it will be beneficial to you.
Protocols, products, and the services available to them. Dental Learning is an ADA-served recognized provider and an approved PACE provider by the Academy of General Dentistry. We are also a Dental Board of California CE provider. This activity is designated for 1 CE of credit. Your Your verification of participation form will be sent to you via email within 2 weeks following the program. It is my pleasure to introduce our speaker today, Dr. Fiona Collins. Dr. Collins has authored and presented CE courses to dental professionals and students in the United States and internationally, and has been an active author, editor, speaker, and consultant in the dental industry for several years. She is a member of the American Dental Association and the Organization for Safety, Asepsis, and Prevention, and has been a member of the British Dental Association, Dutch Dental Association, the International Association for Dental Research, and the Academy of General Dentistry Foundation Strategy Board. Fiona is the CE editor for dental learning, and she earned her degree from Glasgow University and holds an MBA and MA from Boston University. Dr. Collins is a speaker on infection control and has received speaker support for courses from Felton Healthcare and Duck Dental. Dr. Collins can be reached at fionacollins@comcast.net. Tonight's program is not funded through any commercial support. Please join me in welcoming Dr. Collins.
So the title for this evening's presentation is Infection Control, Dental Unit Waterlines and Amalgam, Myth and Reality. The educational objectives for this evening's presentation are to be able to list and describe the role of dental unit waterlines in cross-contamination and the transmission of microorganisms. To be able to describe infection prevention protocols as they relate to dental unit waterlines, to be able to review available evidence on dental unit waterline treatment options, and to be able to describe best practices for the handling and disposal of dental amalgam. Let's look first at dental unit waterlines. The overall goal of infection control is to prevent the transmission of microorganisms and disease prevention. Let's look first at the chain of infection. In 2003, the Centers for Disease Control and Prevention published Guidelines for Infection Control in Dental Healthcare Settings, 2003. Infection prevention guidelines and a series of steps must be followed for infection prevention and in accordance with OSHA regulations. The chain of infection requires that a reservoir or source be present for a pathogen at a level sufficient to result in infection. A source or reservoir could be a person or an inanimate object. Transmission may be through direct contact with oral fluids, blood, or other patient materials, or indirect transmission, for instance, resulting from contact with a contaminated instrument. An entry portal must also be present, and finally, the host must be susceptible. Let's now look at dental unit waterlines and how they may contribute to the transmission of microorganisms and disease. Dental unit waterlines convey water to handpieces, ultrasonic scalers, air water syringes, the cuspidor, and the rinsing cup. So how are dental unit waterlines contaminated? These waterlines are mainly contaminated from the public water supply, which contains small numbers of microorganisms. Contamination can also occur as a result of backflow, also known as suckback or retraction. A third method of contamination is from reservoir bottles in dental unit waterlines. This occurs when reservoir bottles have been incorrectly handled, and Staphylococcus aureus, for example, has been found in reservoir bottles, the result of skin shedding from handlers while they were handling the bottles. So how does dental unit waterline biofilm form? It forms in the same way as other biofilms. The first step is the development of a conditioning pellicle. In the case of oral biofilm, we're all familiar with this as the salivary or acquired pellicle. Inanimate objects also acquire a pellicle. Microorganisms then start to adhere to the pellicle, initially reversibly, and are called pioneers. These accumulate on the internal surface of the waterline lumen. They then supply sites for the adhesion of other microorganisms. The microorganisms release extracellular polysaccharides, also known as exopolymers, that not only aid adhesion, but also protect developing and mature biofilm. This is exactly the same process that we are familiar with dental plaque or dental biofilm. The stages involved in biodevelopment are initial colonization by pioneers, further colonization by microorganisms, followed by growth, maturation, and finally dispersion or dispersal. Dental unit waterline biofilm is a complex structure. It secretes polysaccharides that form the sticky, slimy matrix. It also secretes lipids and contains lipids, proteins, as well as other components. It's self-protecting and protected further by the nature of the dental unit waterline. Here we can see a scanning electron micrograph of a biofilm. The bacteria and matrix in which they are embedded is clearly visible. In this case, the biofilm is from the surface of a medical catheter that eventually had to be removed. However, microorganisms and the sticky matrix are a hallmark of all biofilms and the structure that protects them from antimicrobials. So why do dental unit waterline biofilms form quickly? Biofilm formation on new dental unit waterlines takes just hours, with microorganisms forming a biofilm on the lumen surface of the waterline. This biofilm formation is aided by the narrowness of the lumens, just 2 to 3 millimeters in diameter. The surface area of the waterline is large relative to the three-dimensional area of the lumen. The water in these narrow lumens is also slow flowing by nature and frequently stagnant, aiding biofilm development and giving microorganisms more opportunity to adhere. Furthermore, once dental unit waterline biofilm is formed, it is difficult to access and remove. In addition to being frequently stagnant during the day, these waterlines are stagnant all night when not in use. Here we can see the laminar flow that occurs inside a dental unit waterline. There is faster flow in the middle of the lumen and slower flow towards the periphery. It is stagnant at the interface of the lumen and the water flow. The hydrodynamic layer, or the hydrodynamic boundary, is the area where the water is very slow flowing and where microorganisms have an opportunity to adhere. Once the conditioning pellicle had formed, biofilm formation began. The majority of microorganisms in dental unit waterlines, as stated before, are from the public water supply and are heterotrophic. However, potentially pathogenic microorganisms are also found in dental unit waterlines. These include Pseudomonas aeruginosa, non-tuberculous mycobacteria, Legionella species, and Staphylococcus aureus. Hepatitis C viral DNA, Legionella, and mycobacteria have also been identified from dental unit waterlines. So how are patients exposed? Dental unit waterline connected devices can transmit microorganisms into a patient's mouth or waterlines. These microorganisms may be aerosolized from equipment, either directly or from the patient's mouth, and then inhaled or settle onto environmental surfaces. During the operation of dental chairs, the shear force generated within dental unit waterlines detaches pieces of biofilm. Legionella species and mycobacteria from dental unit waterlines have been identified in aerosolized microorganisms. As mentioned, dental unit waterline connected devices can transmit microorganisms, and this can be aerosolized. In one multi-chair setting, a study was conducted with one of the testing sites selected outside an 11-meter radius of the treatment site. Yet, this still showed significant contamination following aerosolization 3 hours post-treatment compared to pre-treatment. Transmission of pathogenic human-derived microorganisms such as Staphylococcus aureus is possible. This is carried from the nasal cavity in a significant proportion of humans and migrates readily from the nasal to the oral cavity. One recent study reported the isolation of Staphylococcus aureus from saliva in 46% of patients sampled and from 34% of plaque samples tested. Until recently, however, there was no confirmed report of disease transmission resulting from contaminated dental unit water lines, although there were several unconfirmed reports. Earlier reports existed but were not definitive, including the death of a dentist from Legionnaire's disease. That changed recently with a confirmed case of Legionnaire's disease. Let's look first at the suspected case in the dentist. It was concluded that his death was probably caused by occupational exposure to Legionella bacteria-contaminated aerosols. While high levels of this were found in the dental unit waterline output water, in fact more than 10,000 organisms per ml, only low levels were found in his domestic water supply, less than 100 organisms per ml. It was not possible, however, to confirm that this was the definitive source of disease transmission. In 2012, an octogenarian in Italy died of Legionnaire's disease. This was found to be associated with the transmission of Legionella from the dental unit waterline while she was receiving routine dental care. She died after several days in intensive care in the hospital. Other sources were ruled out, and it was found that this was likely transmitted by aerosolized water from the high-speed handpiece turbine. What else? Other health problems associated with dental unit waterlines have also been found. Occupationally acquired antibodies to Legionella and Neophilia strains have been found in dental healthcare workers. Further, levels of up to 100,000 bacterial endotoxin units per ml have been reported in dental unit waterline output water. And exposure to aerobic bacteria endotoxins from contaminated dental unit waterlines was found in one study to be associated with occupationally acquired asthma. Let's look now at breaking the chain of infection and preventing transmission with respect to dental unit waterlines. The CDC guidelines state that dental unit waterlines should contain bacterial levels that are no more than 500 colony-forming units per ml, the acceptable level for aerobic heterotrophic non-coliform bacteria in drinking water. Note, however, that during surgical procedures, only sterile water may be used, and that this recommendation applies regardless of the level of microorganisms in the dental unit waterline output water. This digitally colorized scanning electron micrograph is of an untreated water specimen that was extracted from a wild stream. This stream was mainly used to control flooding, and shows a biofilm enmeshed with microorganisms. It also draws attention to the necessity for boil water advisories. During power outages, the functionality of treated water systems can be negatively affected. In these instances, a boil water advisory may be posted. When a boil water advisory exists, the public water supply may not be used for any patient care. There are several methods that can be used that can contribute to improving and maintaining dental unit waterline water quality. These include anti-retraction valves, daily draining and purging, independent water systems, point-of-use filters, microfiltration, water purifiers, chemical treatments, and recently autoclavable water systems. Conventional tubing is made of polyurethane. Some materials may be more effective at resisting biofilm formation. These still, however, permit biofilm growth. In the field of biofilm research, one of the novel technologies being investigated involves the use of anti-biofilm materials that inhibit biofilm formation. The only option that can inactivate and remove existing biofilm is the use of chemicals on a regular basis. Chemical agents used for the treatment of dental unit water lines include hydrogen peroxide, alkaline peroxide, chlorhexidine gluconate, silver, sodium hypochlorite, a bleach, and chlorine dioxide. Many different types of treatments are available, and a full discussion is beyond the scope of this presentation. Options include shock treatments and cleaners. Vehicles include liquids, tablets, and cartridges. And some require daily, weekly, or monthly maintenance. Dental unit waterline manufacturers and waterline treatment manufacturers and distributors can also be consulted on suitable options for a unit. If reservoir bottles are used, utility gloves should be worn and exposed skin avoided when handling these to prevent contamination of the water with microorganisms. The bottles should be cleaned and disinfected regularly, or if autoclavable, should be autoclaved regularly. With closed water systems, it is important to avoid touching the tubing to prevent contamination. The maintenance instructions of the dental unit manufacturer must be followed, as must the recommendations on monitoring water quality. Testing for water quality can be performed in the office or in an external laboratory. It can be performed by taking water from each of the outlets to obtain a representative sample on a regular basis. Recently, new technology has been introduced that utilizes an autoclavable cassette system and involves sterilization of the water container, and waterline tubing for the handpiece air and water syringe. In summary, on dental unit water lines, these are predisposed to the formation of biofilm. Dental unit water line biofilm poses a risk for disease transmission, and confirmed and suspected cases of disease transmission have both now occurred. Dental unit water line must have at least the same water quality as the public water supply. And finally, measures are required to ensure that dental unit water lines do not contribute to the transmission of microorganisms and disease. Let's now turn to considerations and best practices with amalgam use. And I will be happy to accept questions and will be able to answer those at the end of the presentation. Thank you. From a historical perspective, various types of amalgam have been used with a long history of use overall with amalgam. Pierre Fauchard, the French dentist after whom the Pierre Fauchard Academy is named, and the father of modern dentistry, recommended an amalgam in the 1700s. This amalgam was called Plomagel and contained lead. Improvements were made over time, including in the United States and the United Kingdom during the 1800s and later. Amalgam containing silver and mercury was introduced with two variants developed, one by Thomas Bell of Guy's in London and another by G.V. Black, whom we associate with preparation classifications for direct restorations. So why is dental amalgam used? It's effective, durable, it offers low wear over time and easy handling, as well as some moisture tolerance. It is also relatively low cost, which can be a plus in global oral health care. The choice of materials for dental caries management, according to the World Health Organization, depends on a number of factors such as the tooth, the site, the size of the carious lesion, but also as well the healthcare provision and financing, patient preference, healthcare provider preference, technology, cost, and environmental factors. Dental amalgam has a long-term clinical history of success. It is durable with a median range in age of 10 to 15 years based on systematic reviews. The failure rate is approximately 2.2% per annum, and success has also been achieved with amalgam bonding. However, there are other aspects with dental amalgam. It is not aesthetic, there is no fluoride release, there are health controversies, and there are also concerns about mercury. Let's examine the evidence for the safety of amalgam restorations firstly. There have been many suggested associations for dental amalgam. These include neurological diseases, psychological psychiatric effects, renal, cardiac, and thyroid diseases, immunosuppression, chronic fatigue syndrome, developed problems, and even infertility. There are additional associations that have been suggested. Let's look at the research results. In one New Zealand study in 20,000 military personnel, a 20-year study that was conducted, there was no evidence found for renal disease, no evidence for chronic fatigue syndrome as the result of exposure to mercury through dental amalgam, and there were too few cases of Alzheimer's or Parkinson's disease to draw any conclusions. It has also been discovered that no differences in brain mercury levels were found in Alzheimer's patients compared to control patients. In a second study of less than 2,000 participants, no evidence for a role was found with decreased neurological function. In other studies, no evidence was found for ALS, with no differences in brain mercury levels. No evidence was found for autism or birth defects, for low birth weight babies, and no association was found for multiple sclerosis. In two studies of children, comparisons were made between amalgams and composites. In a 5-year randomized prospective study by Bellinger and his colleagues, no differences were found in renal function. The children in the study were 6 to 10 years of age when the study began and received either amalgam or composite restorations from that point on for the 5-year period. In addition, in children, studies have found no differences not only in renal function, but also no differences were found in IQ or memory. As with the other metals, however, allergic reactions can occur, including contact dermatitis and localized reactions. Patients with oral lichen planus have demonstrated higher percentages of positive skin patch tests in reaction to dental amalgam. In those cases, it has been found that the removal of amalgam helped to resolve the lichen planus. Amalgam tattoos can also occur. These are harmless. Let's now look at occupational exposure. No studies have been found showing dental personnel suffering classical signs of mercury intoxication, and this is based on a review by the EU Scientific Commission on Emerging and Newly Identified Health Risks. No link has been found with negative health effects or mortality, although higher blood mercury levels have been found in dental personnel compared to the general population. In a separate study in Raccoon, the lifespan of dental personnel was found to be greater than in the control group. In summary, no link has been detected between mercury exposure and negative health effects in dentists. In a prospective study that was conducted in Scotland, the impact of mercury on dental personnel was also assessed. This was a 35-year study. From 1975 until 1994, hair, finger, and toenail samples were taken from dental personnel. From 1995 until 2010, when the study concluded, only head hair samples were taken. In the initial period from 1975, for many years, there were high levels of mercury found in all samples, i.e. in hair, finger, and toenail samples. Open-toed shoes were also found to be associated with higher levels of mercury in toenails. In subsequent years, the level of mercury found decreased and was substantially lower in the headgear-only samples from 1995 onwards. This was attributed to safer handling of amalgam, as well as the use of personal protective equipment. Exposure incidents with amalgam are now rare. Let's look at statements from governments and non-governmental organizations. The FDA Advisory Council in 2006 found no evidence that amalgam use causes health problems in a majority of the population. The FDA considers dental amalgam safe for adults and children aged 6 and older. It cautioned individuals with allergies to ingredients that were present in dental amalgam not to have amalgam fillings. The World Health Organization report of 2009 stated that dental amalgam remains a dental restorative material of choice. The FDI declaration of 2009 stated amalgam is a safe, widely used and affordable dental filling material and currently serves the oral health needs of the majority of communities around the world, particularly those most disadvantaged and in need of dental care. Most recently, the American Public Health Association in 2012 concluded that dental amalgam was a minimal contribution to environmental mercury contamination, and that if amalgam were restricted or banned, that a negative health impact would result, particularly in poorer areas and where amalgam is relied on more heavily. Training in the handling of amalgam was also recommended, as well as collaboration between dental professionals and regulatory agencies. Let's now look at mercury. Natural sources of mercury include methyl mercury produced by fungi and microorganisms, mercuric sulfide found in cinnabar ore, mercury released from volcanoes, and mercury present in the atmosphere. Let's now consider briefly the types of mercury. The first, liquid mercury, requires long-term exposure and or a very high dose for it to be toxic. The main route by which mercury toxicity occurs is through inhalation. The second type of mercury is inorganic salts of mercury. These are mercury compounds formed with a combination of, for instance, chlorine or sulfur with mercury. Cinnabar ore is an example of an inorganic mercury salt. Both of these types of mercury are immunosuppressive. The third type of mercury is organic mercury, mainly methyl mercury, and this is of most concern. Methyl mercury is the most potent of the mercuries. It is bioaccumulative and mainly acquired through ingestion, although it can also be inhaled or absorbed. Adverse health effects at high doses long term include damage to the nervous system, respiratory, and renal systems. It can also affect vision, result in tremors, paralysis, and developmental problems have also been reported. In the early phases of mercury poisoning, reported signs have included gingivitis and an enlarged thyroid. We probably all can remember the phrase "mad as a hatter" and the Mad Hatter in the book Alice in Wonderland. In fact, hatters in the past used mercury during the making of hats, and it's to this practice that the term has been attributed. So how does dental amalgam come to contribute to mercury pollution in the environment? Dental amalgam can end up polluting the environment in a number of ways. If it is not disposed of appropriately, it can end up in landfills and leach into the waterways in large quantities. Or if present in a sludge and discarded from vacuum pumps or chairside traps, this can evaporate, releasing mercury into the environment. A third manner due to inappropriate disposal is if this is sent to an incinerator along with other trash. If amalgam is sent to the incinerator, in the process of it being incinerated, it will release mercury into the atmosphere. Finally, dental amalgam could be rinsed into the water system or reach the public water supply treatment plants through evacuation lines. Although treatment plants are designed to remove dental amalgam, they are not fully effective and remove approximately 90%. Therefore, by allowing dental amalgam to reach the water treatment plant, some amount of dental amalgam will reach the environment and pollute. It should be remembered that dental amalgam contributes a small portion of the total amount of mercury released to the environment by humans. However, this should still be prevented and minimized. Mercury from all sources reaches waterways, such as rivers and streams, and the atmosphere. Bacteria can transform inorganic mercury into methyl mercury. This then becomes part of the food chain, in the case of fish concentrating within them. And many of us will have seen signs such as the one we are now looking at, warning of a health hazard with fish being caught that had been feeding in particular areas. %80 of mercury comes from 5 groups of products. Top products include batteries, measuring devices, mercury-containing lamps and bulbs, electronic switches, and relays. Dental amalgam is number 5 on the list. Let's now look at dental amalgam waste. In the United Kingdom, it has been estimated that in 2005, 7.41 tons of mercury were discharged into the air, land, and sewers. In addition, another 11.5 tons were sent for recycling or with clinical waste. In the European Union, it was estimated that 55 to 95 tons of amalgam are used annually. And Environment Canada has estimated that more than 1/3 of the mercury load in sewers is derived from dental amalgam. In the United States, the Environmental Protection Agency has estimated 3.7 tons of mercury each year reach public water supply treatment plants from dental offices. They have also estimated that 50% of all mercury entering the treatment water plants is from dental amalgam. Separate study estimated 40% of the mercury in wastewater was from dental amalgam. And yet another study estimated that 0.45 tons of mercury related to dental amalgam are currently discharged into surface water from public water supply treatment plants. Here we can see the pathways globally and the relative amounts by which mercury reaches groundwater, surface water, through amalgam recycling. The amount with secure disposal is 40 to 50 metric tons. How much reaches the atmosphere and how much is in the soil. There has been reduced use of amalgam over time. In the Netherlands, it now accounts for less than 10% of restorations. In Finland, less than 5%. The amount varies greatly, however. In Japan, it is just 4%, and in the Philippines, 70%, while in certain Scandinavian countries, the use of dental amalgam is banned. Whether or not dental amalgam is used depends on several factors, including cost, availability, preference. In Kuwait, for example, 50% of restorations placed in government clinics are dental amalgam, while only 20% of those placed in private clinics are dental amalgam. A further consideration that has led to reduced use of amalgam is the unaesthetic nature of amalgam and the aesthetic nature of direct tooth colored restorations. A memorandum of understanding was signed in December 2008 by the American Dental Association, the Environmental Protection Agency, and the National Association of Clean Water Agencies. This memorandum of understanding was to promote voluntary use of the American Dental Association's best management practice. An Environmental Protection Agency ruling is still anticipated. Over the last 4 years, work has been conducted on creating an international treaty on mercury. This was agreed to at the beginning of this year and could be signed as early as October this year. Components of the treaty include the intent to minimize and, where possible, eliminate mercury supply, unintentional mercury, the global use and demand of mercury, and to promote non-mercury technologies. This applies to all mercury use and all mercury technologies, not only dental amalgam. This treaty is a partnership and will lead to reduced mercury use and mercury control. Best management practices of the American Dental Association include the use of amalgam separators that comply with ISO 11143. Amalgam waste should be captured and recycled. Recyclers should be contacted to find out what they accept, how it should be packaged, and whether you should also find out whether the recyclers ANSI ADA 109 compliant. There are several sizes of amalgam capsules available. Using the size suitable for the restoration avoids the possibility of excess waste. Amalgam separators do not split mercury from the amalgam, although the name may suggest this. They separate amalgam solids as well as other solids in the evacuation line. These solids are then collected for recycling. The ISO standard is that amalgam separators must capture at least 95% of amalgam. There are many different types of amalgam separators. Ease of installation, low maintenance, and cost are all considerations. However, the use of amalgam separators is only mandated in some states and in some municipalities. Elsewhere, their use is voluntary. Lower use has also been found in areas where the use of an amalgam separator is not mandated. Additional sources of amalgam waste include used capsules, the non-contact scrap or excess that is derived from capsules when the restoration is substantially smaller, old and new amalgam trapped in the cuspidor and in traps, and old amalgam in extracted teeth. Amalgam waste must be disposed of properly in used containers and appropriately recycled. It is important not to rinse out full canisters, not to dispose of amalgam in the general trash or in the hazardous waste container. And amalgam solids must be disposed of appropriately in accordance with recommendations and regulations. Retorting is also a possibility, and this separates out the mercury and condenses the mercury for recovery. Disposal should be in wide-mouthed, airtight containers. These can be marked contact amalgam waste for recycling, non-contact amalgam waste for recycling, and amalgam capsule waste for recycling. This is a label provided by the EPA. The EPA has recommended grey bagging in grey containers and that these should be stored and shipped to recyclers for safe disposal. Containers should not be placed in the general trash, nor should they be sent to incinerators where their incineration would release mercury. Actions may be abbreviated as GRID. Grey bag it, recycle it, install it, and teach it. These highlight some of the ADA's best management practices for amalgam waste. Evacuation line cleaner must be used at the end of each day for infection prevention. and are used to inactivate and remove existing biofilm in evacuation line cleaners. Chemical agents that may be used for this purpose include hydrogen peroxide, alkaline peroxide, chlorhexidine gluconate, sodium chloride, and chlorine dioxide. However, it is important not to use a line cleaner based on chlorine, so these can cause mercury release. It is also important to remember to wear personal protective equipment while cleaning evacuation lines as well as the operatory. Safety glasses or a full face shield that is impact resistant and with side protection should be worn, as should a mask and heavy duty utility gloves. Here are some do's with respect to amalgam. Do use single-use pre-capsulated amalgam. Do use chair traps and vacuum traps. Wear personal protective equipment, grey bag amalgam, and appropriately recycle amalgam, including amalgam contained in restored extracted teeth. Some of the don'ts are not to use bulk mercury or to mix amalgam, not to discard used capsules or amalgam in the trash, not to use medical waste bags for amalgam, as these can end up in the incinerator and release mercury, not to rinse containers over the sink or water, which would introduce amalgam into the water supply, not to discard amalgam, old or new, into the water system by flushing, and again, not to use a chlorine-based cleaner. In summary, amalgam is a safe and effective restorative. Mercury pollutes the environment. Steps can be taken to minimize mercury contamination resulting from the use of dental amalgam. Using a separator, suitable line cleaner, and recycling or discarding of amalgam appropriately helps the environment and is an important contribution globally to reducing the mercury released into the environment. Thank you very much for your attention.
Thank you, everybody. Any question from the audience? أي سؤال يا أخوان? Any question before we go to the break? شكرا حنين, سوسن, لاميا, Ahmed, Sarah, thank you very much, all of you. Arwa, Amal, thank you. Ali, thank you. Asma, thank you very much. Salman, thank you. Rahman, thank you, all of you. سعد, لا ما تطلع, you can go now, لكن خلي الزوم شغال, يعني لا تطلع, don't log out from the Zoom. يعني stay with the Zoom. You can take the break now for Maghrib prayer, صلاة المغرب يا أخوان. لكن خلي الزوم شغال, لا تفصل. التحضير يا أخوان قبل لا تطلعون البريك, التحضير لو سمحتم. اليوم نخلص بحدود 10 بمشيئة الله, يعني 10 وربع, 10 إلا ربع, يعني بحدود الوقت هذا إن شاء الله. أي سؤال يا أخوان؟ Any question؟ التحضير مرة واحدة في اليوم يا أخوان. تحضير مرة واحدة, بس اللي ما حضر يحضر يا أخوان. يعني هو سبب أن نحط الرابط التحضير أكثر من مرة لأنه في بعض الزملاء ما شافوا.
فنحطه مره ثانيه، وبعدين بعد فتره يقول لك فين التحضير فتحطه مره ثالثه. فانت اذا حضرت مره واحده في اليوم كافي. اي سؤال يا اخوان؟ واضح يا اخوان؟ إيه، حتى لو قطع الاتصال ما في مشكله، بس انه ترجع بعد ما تقطع الاتصال ترجع بالزوم. اهم شيء الزوم ترجع تشبكه على طول يعني. والتحضير مره واحده في اليوم. اي سؤال يا اخوان؟ any question؟ طيب يا اخوان يعني يو كان جو لصلاه المغرب، لكن خليك الزوم، خلي الزوم شغال يا اخوان، لا تطلع من الزوم. رابط الزوم موجود في الشات بوكس فوق يا اخوان، اللي فات ويلاقيه فوق. قبل تطلع للصلاه يا اخوان حضروا بس في الرابط لو سمحتم. التحضير مره واحده في اليوم فقط، يعني امس تحضر، اليوم تحضر، بكره تحضر. مره واحده طبعا، كل يوم مره واحده. طيب يا اخوان نراكم ان شاء الله على الساعه 7:15 بعد صلاه المغرب ان شاء الله، وخلوكم شغالين على الزوم، لا تفصلون من الزوم. نراكم على خير ان شاء الله. Welcome everybody to our next presentation. It's about room disinfection automation. Conventional disinfection methods are limited by reliance on the operator to ensure appropriate selection, formulation, distribution, and contact time of agent. No-touch automated room disinfection NTD system remove or reduce reliance on operators, and so they have the potential to improve efficacy of terminal disinfection. The most commonly used system are hydrogen peroxide vapor, aerolized hydrogen peroxide, ultraviolet radiation. These systems have important differences in their active agents, delivery mechanisms, efficacy, process time, and ease of use. The choice of NTD system should be influenced by the intended application, the evidence base for effectiveness, practicalities of implementation, and cost constraints. نخلص الساعة 10 اليوم إن شاء الله. 10 وربع يعني بحب هذا الوقت تقريبا. Four classes of NTD system that are most commonly used in healthcare setting. And there are differences between these systems in terms of their technological aspects, microbiological efficacy, evidence of clinical impact, and practicalities. Recent data indicate that contaminated surfaces make an important contribution to an endemic transmission of certain nosocomial pathogen. Improvement of these conventional methods require modification of human behavior, which is difficult to achieve and sustain. The use of NTD system provides an adjunctive approach which removes or reduces reliance on the operator. It depends on characteristics of organism involved, patient susceptibility, and staff compliance with universal precautions and infection control policies. Most strains targets should be set when suitable. Conventional cleaning and disinfection without programs of targeted improvement rarely eliminate pathogens from services. Problems associated with both product and procedure contribute to the failure of conventional cleaning and disinfection. The key problem associated with the cleaning and disinfection procedure is the reliance on the operator to repeatability, ensure adequate selection, formulation, distribution, and contact with the agent. Distribution of active agents is difficult in the complex and indirect healthcare environment. Ensuring the correct contact time to attain the microbial reduction achieved in vitro is particularly problematic because the disinfectant will evaporate from the surface. The delegation of responsibility for cleaning, difficulties in measuring the effectiveness of cleaning and disinfection, poorly paid, poorly motivated workforce who may have limited spoken or written local language skills, inadequate training, time given, or insufficient cleaning prior to disinfection, or incorrect formulation of the disinfectant, contamination of cleaning solution and materials. The most commonly used NTD system in healthcare are AHP system, H2O2 vapor system, and ultraviolet C system. A fourth class of NTT is PX UV radiation, has been introduced recently and has been subject of a few limited studies so far. The ideal system would have a short cycle time, a high efficacy to eliminate pathogens from surfaces, homogeneous distribution of the active agents. The system should be easy to operate, allow instant access to the room, and the system should have published evidence of a clinical impact. Clearly, no single system meets all of these requirements, and the importance of each feature will depend on the application. commonly used systems. يا اخوان فيه بعض الزملاء يقول ما في صوت، الصوت واضح لو سمحتوا؟ الصوت واضح يا اخوان؟ طيب شكرا جزيلا للجميع، شكرا. The AHP system deliver a pressure generated aerosol. The systems used most commonly in healthcare use solution containing 5% hydrogen peroxide less than 50 pp sulfur. These systems are sometimes known as a dry mist hydrogen peroxide, though this term is poor reflection of their properties. Aerolized droplets are introduced into enclosure via unidirectional nozzle. Following exposure, the aerosol is usually left to decompose naturally without any active aeration. H2O2 vapor system deliver heat generated vapor up to 35%. Biocool system are usually termed hydrogen peroxide vapor and sterile system vaporized hydrogen peroxide. A control pedestal is situated outside the enclosure to provide remote control. Sterile VHP system have a generator inside the room with an integral aeration unit and dehumidifier designed to achieve a set humidity level prior to the start of the cycle. UVC system for room decontamination delivers specific dose of 254 nanometer range to surfaces. Some manufacturers therefore recommended multiple cycles from different locations Some UVC system contains sensor to measure the amount of UVC light reflected back to the device to confirm the delivery of specified dose to all parts of the room. One AHP system achieve 4 log reduction of posterior deficit spores in vitro and has limited capacity to activate commercially produced 6 log spores biological indicators. AHP system have been shown to reduce contamination, posterior deficit, and MRSA in hospital services, but have not been shown to eliminate pathogens in clinical practice. Both Biquel HPV and Series B HP systems, Environmental Protection Agency, register surveillance, which means they have passed AOE sporocyte test on porous and non-porous surfaces. Both systems are associated with the elimination of pathogens from surfaces inside. Though efficacy may be reduced by high microbial loading and the presence of organic soil, ultraviolet produce dose-dependent 2 up to 4 logs reduction of nosocomial pathogens. Several studies of one UVC system indicate a significant reduction of surface contamination measured by total aerobic count or sampling for specific pathogen. Several studies of one UVC system indicate a significant reduction of surface contamination measured by total aerobic count or sampling of specific pathogens. HPV has been used to remove environmental reservoirs during outbreak of sterile deficit. MRSA, MSSA, multi-drug resistant, and other pathogens. PHP has been used for tackling environmental reservoirs during outbreak of Acinetobacter baumannii and torricollis. The clinical impact of BHP, aside from outbreak setting, is not reported. On the other hand, 3 studies have assessed the impact of HPV in the setting of endemic infection. An observation before and after a study showing that HPV decontamination of room vacated by patients with sterile deficit infection significantly reduced the incidence of CDI, both on targeted wards and hospital-wide, when analysis was restricted to the month when the epidemic strains was known to be present. That HPV was microbiologically superior to the quadruple bleach disinfectant. Since HPV has time and efficiency saving compared to quadruple bleach disinfection, it was cost effective to use HPV in this setting. HP is straightforward to use and relatively inexpensive compared with H2O2 vapor and UVC system. The capacity of single units to decontaminate areas larger than single room is limited. Doors and air vents should be sealed and handheld health. Several studies suggest that homogeneous distribution several studies suggest that homogeneous distribution of the active agent is not achieved, perhaps because AHP is introduced via unidirectional nozzle and particles are affected by gravity. Sublethal exposure to hydrogen peroxide and silver could result in the development of tolerance or resistance. The potential for transversible resistance to silver is greater than for hydrogen peroxide due to plasmid-mediated silver-resistant genes. The potential for transient resistance to silver is greater than hydrogen peroxide. Data are required confirming the compatibility of AHP system with common hospital materials, including sensitive electronics. Several studies have noted equipment reliability problems. تسجيل الحضور مرة واحدة يا اخوان، نعم اللي حضر في اليوم هذا خلاص، بكره في تحضير ثاني لليوم الاخير. بس اذا حضرت في يوم واحد خلاص نفس اليوم طبعا. H2O2 vapor system have been used to decontaminate rooms and entire units. As with HP, handheld health and safety monitors are required to ensure that no leakage occurring during cycles. Staff training required for using H2O2 systems are higher than ultraviolet systems. لا إذا سجلت في الرابط مرة واحدة كفاية حتى لو فصل النت. إذا فصل النت ترجع على طول على الزوم علشان الوقت محسوب. Reported cycle times are currently 1.5 up to 2.5 hours for single room and 8 hours for BHP. UVC is easy to use, does not require sealing of doors or air vents, and has a relatively short cycle time. Many high-touch sites may be out of lines. Some manufacturers recommended multiple cycles in different parts of the room to overcome this problem. The intensity of ultraviolet light dissipates with a square of the distance from source, which limits the capacity of single UVC devices to disinfect areas larger than single patient rooms. The long-term impact of UVC in hospital materials has not been described. UVC is relatively expensive compared with other NTT systems. UV radiation is a known mutagen. PX UV system have similar practical consideration to UV system, including the need to use multiple room locations, the potential for mutagenesis. Also, the system operates using a series of bright camera flashes, which may be disruptive to patient and staff outside the room. The performance of different systems can be evaluated by several measures, including compliance with testing standards, in vitro log reduction of bacterial loads, measurement of microbial surfaces contamination before and after treatment, by the use of BI with known concentration of microbes, typically bacterial endospores. BI can be produced in-house or more reliably can be purchased commercially. However, comparison of relative effectiveness of different NTD systems is difficult because variations in sample sites, patient infection or colonization status, the organism, the microbiological testing methods, the type of pre-clean. The best way to compare different systems is through controlled head-to-head studies, ideally using outcome related to reduced transmission in clinical settings. However, there have been few studies comparing these outcomes, so it is not possible to evaluate the relative clinical impact in NTD system using current data. The NTD system can be purchased, rented, or introduced as a part of service contract. These deployment models have different costs depending on the package and any frequency of use. For hospitals that purchase their own NTD system, upfront cost, including equipment itself. For hospitals that choose to purchase a service or other model manufacturers should be contacted to discuss available options. Consumable cost for hydrogen peroxide systems are likely to be greater than cost of bulb replacement for ultraviolet system. No studies of the cost effectiveness of NTD system have been published. Performing a cost effectiveness study on the use of NTD system should consider the direct and indirect costs associated with the system. Current CDC guidelines recommend against routine disinfectant fogging. The strongest reason for considering an NTD system is to break the chain of transmission by improving terminal disinfection of clinical areas. NTD systems are not suitable for performing disinfection of general clinical area. NTD systems have been used to control endemic infection and outbreaks. The different indications for the use of NTD system are outlined in the following scenarios. The choice of whether to rely on current cleaning and disinfection methods enhanced the conventional methods or an NTD system will be determined by the clinical scenario. The risk associated with individual pathogen in the context of disinfection will depend on a number of factors, including the importance of environmental contamination, clinical implication, local epidemiology, and financial outcomes. Closure may have particularly adverse impact when they involve specialist regional units such as those of neonatal, pediatric, adults, and intensive care. Conversely, H2O2 vapor system would be appropriate for dealing with high-risk pathogens in high-risk units because of their high level of efficacy. UV and hydrogen peroxide systems may be suitable for disinfection of single rooms in low-risk settings with high risk. As well as with all forms of decontamination, cleaning is required prior to NTD disinfection system used in order to remove organic matter that reduce the effectiveness of NTD system. Nevertheless, several studies demonstrate that NTD system can produce significant reductions in environmental contamination even without pre-cleaning. One of the problems of conventional cleaning and disinfection is the difficulty in validating the process. The major advantage of NTD system is the reduction or removal of reliance on the operator to assure adequate distribution and contact time of disinfectant. NTD system could be validated by routine microbiological sampling using conventional standards, but this is the time-consuming, costly, and require microbiological expertise. The question remains as to whether 6-logs BI are appropriate tests for validating NTD system. Recent evidence published indicate that catalase-positive bacteria are less susceptible to hydrogen peroxide. The US EPA requires hospital disinfectant to achieve more than 6-log reduction. This is higher than the concentration typically found in hospital services, presumably to provide assurance that the disinfectant will be effective in the real world. Given the relatively recent introduction of NTD system into marketplace, regulatory standards have not been established. Testing standards are generally not specified for NTD system. Currently, it is not clear how the BBD will influence NTD system, although the NTD will need to be assessed and registered as with any other disinfectant. So in conclusion, there is no evidence that existing NTD systems are effective adjunct to conventional methods of terminal disinfection. And further evidence on the optimal application of cost effectiveness of NTD system in healthcare is required. NTD system has already beginning to be integrated into hospital disinfection policies. Regulators and professional bodies should decide on the terminology and insist on standardization for these systems. I think that was the last slide. أي سؤال يا أخوان? Any question? Thank you, Reem. Thank you, Abrar. Basma, Ahmed, thank you very much. Mona, Muhammad, thank you, all of you. Ahmed, Amal, Muhammad, thank you, all of you. Thank you very much. Abdullah, Abdul Rahman, Nizar, Samar, Muhammad, thank you, all of you. Okay, we'll move to the next presentation if there are no questions. Microorganism control. If we're speaking about bacteria, we have to discuss Pseudomonas, Legionella, HAI, built environment, and Legionella. The concept and practices of modern healthcare have introduced hazards not foreseen by their originators. Some of these have to do with the built environment, and those of Legionella and Pseudomonas aeruginosa relate to water distribution within healthcare premises. This lecture to outline the risk to patients and control these unintended hazards. In the healthcare arena, the concept of unintended consequences usually serves as a heterogenic disease. The history of hospital design goes back millennia, but in recent decades, we have learned a number of important lessons with regard to building services and their impact on the vulnerability. The problem associated with the water distribution system is healthcare, and healthcare were all unintended. It was the Bellevue Stratford Hotel, Philadelphia, in 1976, where there was an American Legion of Department, Pennsylvania, which was held. Epidemiologists and laboratory investigators worked diligently to establish a cause of explosive outbreak of respiratory disease that involved 149 of the conventioneers. Further investigation established an additional 72 cases, a number of public who had not played any part in the convention, but had all been within the vicinity of Bellevue Stratford Hotel. Of 221 people who became ill, 34 died. From the post-mortem tissue of legionnaires who died, and using techniques designed to isolate rickettsia, the causes of bacterium Legionella and Ophelia was isolated. Using fluorescent antibody techniques, specific immune response was demonstrated in the sufferers, which associated the organism with casualty. The bacterium could not be seen in ordinary gram stain of lung bacteria. Having discovered the new pathogen, it soon became evident that this was not the first time that Legionella had caused an outbreak of pneumonia. A retrospective review carried out by the Center of Disease, CDC Atlanta, in 1957 outbreak of pneumonia in a meat packing plant to this bacteria. It also became apparent that Legionella pneumophilia were responsible for separate syndromic illness. It is rare now to see outbreaks associated with cooling towers, as these hazards are well recognized. So other contaminated water sources, humidification units, whirlpool bath, shower, cooling towers, water sprinklers. Although aerolized and inhaled particles appear to be responsible for the disease in 0.2
Source outbreak, most cases appear to be sporadic. The genus is ubiquitous and occurs in many freshwater environments, but grows best in warm waters between 25 and 42. In colder waters that less than 20, their presence could be described as alive but not cultivable. It would seem counterintuitive that a bacterium which is difficult to grow is naturally demanding, but is widely distributed in nature and thrive in a man-made water distribution system. It's achieved this by subverting the phagosome's maturation process. A droplet containing a single free-living parasite amoeba could therefore contain an infecting dose of Legionella. Most environmental bacteria live on interface between solid and liquid environment and biofilm, which are frequently found in water distribution systems. Pseudomonas aeruginosa is inherently resistant to many antimicrobial agents. In 1950s and 60s, there were multiple reports in the literature of fluids such as eye drops. The reports came predominantly from neonatal nurseries, burns units, and neurosurgery, all early practitioners of augmented care. It has been found to be the distal part of water tap. Unlike the rise of Legionella, which has largely remained a community problem, Pseudomonas bacteremia appears to have associated themselves with medical interventions and healthcare premises. Pseudomonas aeruginosa, like Legionella, is not nutritionally exacting. It is oxytroph and acquires its carbon energy source from the environment. There are a number of examples where polymers have been shown to leach carbon sources and as such support and encourage the growth of Pseudomonas aeruginosa. It remains to be seen whether the growth in the use of alcoholic hand drops has contributed to the carbon available for utilization at taps and healthcare premises. Given that under current European standards, there is no prohibition on Pseudomonas entering healthcare premises from supplier. There is no UK quality standard for the presence of Pseudomonas in the distribution system within healthcare. Therefore, we are left with the situation that is left up to a good governance practice as outlined in the Department of Health. Much of the good practice is similar to that needed to be controlled hazards associated with Legionella, but differences do exist. Outbreaks also occur where hand hygiene is at fault, but source has proven to be individual and moist environment. The cause examples include healthcare workers with false negatives.
The use of water from contaminated faucet used for other purposes than direct patient care may also add significantly to the risk of question and infection. It has been suggested that bathing or cleaning of preterm units less than 1.5 kg with water contaminated Pseudomonas aeruginosa was a potential hazard. The feeding of neonates with contaminated milk would encourage early colonization and represent a risk. A similar situation in adult intensive care units might exist in male patients with neck lines who would be wet shaved for aesthetic reasons. A similar situation in adult intensive care units might exist in male patients with neck lines who would be wet shaved for aesthetic reasons. Because colonization from water source may precede infection, other selection pressures such as antimicrobial prescribing are clearly relevant. Care practices such as rinsing of respiratory equipments or the use of tap water modifier have in the best being responsible for nosocomial pneumonia. Outbreaks of Pseudomonas aeruginosa tend to occur in critical settings where patients may be transferred to other providers of care. Legionella hemophilia and Pseudomonas aeruginosa have become successful waterborne pathogens in healthcare purposes. Legionella have the most complex relationships with protozoa, particularly free-living amoeba and other bacterial colonizers. National standards exist in many countries for allowable levels of Legionella and some countries also for Pseudomonas aeruginosa. The status of distribution system with regard to colonization will not be static and may depend on outside factors. Design of new systems and care when combining new and old when commissioning, monitoring of the physical parameters with regard to temperature, where the quality of the supply is variable or poor or the system already widespread contamination and biocides are used at the point of entry. Ensure that chemical or other systems are functioning correctly and achieving the levels of active agents throughout the system. When modifications are made to water distribution system, however minor they appear, ensure the absence of dead legs, that all schematic are extinct. Actively review low-use outlets such as showers used as a store or hand basin, not used frequently, and decommissioning them or institute flushing regimen. When modifications are made to water distribution system, however minor they appear, ensure absence of dead legs and that all schematic are extinct. Actively review low-use outlets such as showers used as stores or hand basin, not used frequently, and decommissioning them or institute flushing regimen. Apply local legislative guidance to monitor of total viable counts. Legionella and Pseudomonas have plans to deal with systems when it is no longer in control. Having a place water safety plan for the building, undertake risk assessment. Have a place in water safety plan for building and undertake risk assessment in units that care for vulnerable patients. During the design stage, the architect and builders will seek to use the most modern plumbing materials that provide cost-effective solutions to the provision of services. We know that the choice of materials may influence the presence of sustainability of biofilm. The use of traditional metallic materials supporting less growth than polymers. However, the use of plastic piping system is approved. They are easier to assemble and require less skill, but may be more likely to support biofilm than more traditional copper. اليوم نخلص الساعة 10 إن شاء الله. Aesthetic are recognized as part of a healing process. Architects will seek to make the environment as pleasing and easily cleanable as possible. Pipe work will be hidden from view, and although designers may be aware of the problems of heat gain, similarly, the placing of pipe work in channels and sealing with other surfaces may also increase environmental heat gain. During construction and before occupation, the water distribution system will undergo testing to determine the presence of leak or other problems. Clearly, this is unsatisfactory procedure as no system will drain down completely, and a period of stasis and stagnation will occur, allowing biofilm to accumulate. The completeness of hyperchlorinated and disinfecting the system will always be in doubt. The alternative system for testing built system might be used in pressure gases. The occurrence of dead legs will hugely encourage the multiplication and resistance of the microbiological flora. Not all stagnation will be immediately obvious. The rise of gram-positive MRSA and Clostridium difficile will come in a new age of infection control. Usage audits may need to be undertaken, and some sinks removed or required to take part in a regular flushing regimen, which may be performed with programmable tabs or manually. United Kingdom guidance on control of Legionella in healthcare premises is very clear with regard to the temperature maintenance. It should be both hot and cold water distribution system, with the aim, of course, being to reduce the multiplication of harmful bacteria, microbiota. For hot water distribution system, minimum temperature at point of generation is 60. And the furthest point in the distribution is 55 Celsius. And because of infection control, need to reduce point of contact where MRSA may exist. Pseudomonas appears to have mostly inhabited the last 2 meters of distribution system and favored particularly the flow straightens found in the termination of the tap. Particular venom has been thrown towards the use of non-touch tap. That is those that are operated by solenoid and that also contain thermostatic mixer valve to control water temperature existing in the tap. They contain a chamber made of polymer that could release utilization carbon. The internal construction allow mixing of hot and cold water so that the spout temperature will not achieve pressurizing temperature. There is a potential for larger residual volumes that will allow large numbers of planktonic cells to accumulate if not flushed. These devices may be installed already contaminated with Pseudomonas from manufacturers who will have tested them on water rig. Pseudomonas generale ubiquitous organism, and therefore elimination from all parts of water distribution system may be unrealistic. The use of biocide following installation of and commissioning is a routine practice, so-called hyperchlorination, but may not be effective once biofilms are established and protozoa present. Treatment of potable water with chlorine is a landmark in the prevention of waterborne disease such as cholera, typhoid, and bacterial dysentery. There are a number of different chemical systems for minimizing the presence of microbial cells within the distribution system. Treatment can be considered as a continuous where they are used to maintain low pathogens numbers in already contaminated system. The use of heat is probably the most effective method to control bacterial numbers. Involves increase the circulating temperature to 60 Celsius plus and flushing outlets for sufficient time to pasteurize the system. This will not work where thermostatic mixer valves are in place, as the temperature on tap will be limited. This will raise the risk of scalding and may not be accepted. Another system of imparting energy is to use ultraviolet radiation within the tap. However, they must be placed within the spout and will have no effect on water upstream. Ozone may be used in similar manner at the point of entry. An effective protection where there is an established risk from contaminated taps or shower is the use of terminal filtration. However, no treatment or engineering solution are guaranteed to be successful in either the short or long term. If contamination is not system-wide, the risk analysis identifies a restricted number of hazard points, and then a long-term point of use filtration remains a viable option. So in conclusion, prevention of illness sits firmly in the realm of state and facilitate management. An ubiquitous organism, their elimination from most premises is not likely to be achieved. The approach to the management of Legionella is well established in the guidance available in the UK and by the state too, that relating Pseudomonas aeruginosa at the time of writing is less well developed. Any question, يا إخوان? أي سؤال? Before we go to Isha break time. Thank you, Hatun. Thank you, Abedallah. Thank you, Khalid. Sausan, thank you, all of you. Mana, thank you. Basma, thank you, all of you. Amna, thank you. Al-Hanouf, Mariam, Samar, Shaima, Basma, Saad, thank you, all of you. Ahmed, thank you. Ali, thank you very much. Badr, Maitha, thank you very much. Okay, we'll be back in 8:45 صلاة العشاء يا اخوان. نرجع ان شاء الله بعد نص ساعة بمشيئة الله. Welcome back, everybody. We will continue our presentation as agreed. It's about PPE. Due to concerns of contamination from a variety of sources, personal protective equipment is used to provide protection to both wearer and patient in healthcare settings. Infection control is important in healthcare environment. Laundering of uniform and correct disposal of single-use products is required to keep infection rates low and manageable. Antimicrobial coating can provide a protection and help prevent growth of microorganisms in textile items. However, durability issues can mean they do not survive on clothing for a full life of item. Personal protective equipment will be featured widely in the healthcare sector in both hospitals and care homes. PPEs include items such as gloves, aprons, eye visors, face masks, and protective footwear. Uniform are not included in the definition of PPE. However, they are used for similar purposes. Patients and staff safety is highly important when working in a healthcare settings. Both uniforms and PPEs are used to provide protection from body fluids, blood, and other contaminants, microorganisms spreading between the staff members and the patient. Infection control is high priority for healthcare establishment. With cost of providing care for patients with healthcare-acquired infection having previously been estimated at around 1 billion annually, although there has been a decrease in the overall number of HAI with 1.5 drop from 8.2 in 2006 to 6.4 in 2011. The development of these infections while the patient is in hospital is of concern, and therefore the use of PPEs, approved infection control procedures, is key in continuing to reduce the rates of infection in hospitals. Antimicrobial resistance cause difficulties in providing treatment for patients with infections. There are several factors which promote antimicrobial resistance, such as poor surveillance, improper use of medication, insufficient research development on new drugs and treatment. Whilst the use of PPEs and uniform cannot reduce antimicrobial resistance, it can help reduce the spread of microorganisms and keep gross contamination to a minimum. Infection control policies and campaigns put in place in hospital are used to maintain high standards of cleanliness and to reduce the spread of microorganisms. There are many microorganisms which cause concerns of healthcare providers, such as Clostridium difficile, MRSA, and Methicillin staph aureus. The bare below elbow BBE policy was introduced in 2007 for these reasons, with the main target being to reduce nosocomial infection caused by MRSA and Clostridium difficile. In comparison, the clean your hands campaign to increase compliance and raise awareness of the importance of hand washing was successful, increasing the amount of alcohol, rub, and soap used in hospitals. Best practice surrounding uniform cleanliness and aftercare is also necessary to prevent any risk of microorganism transmission. Guidelines published by the Department of Health, DOH, stipulate the best practice for laundering and aftercare of uniform clothing. These guidelines are then issued to each hospital trust who develop their own. Therefore, it is unsurprising that variations are seen between trusts. This is in comparison to the guidelines stipulated by the Petro and Stanford Hospital trustee, and the 10 minutes wash at 60 degrees Celsius remove most microorganisms. Although same temperature is stated in both policies, this could cause confusion in staff who transfer to different trusts and remain reasonable for laundering their uniform. Disposable items are worn to provide protection to both the member of staff providing treatment and the patient consent. Contaminants include blood, body fluids, fecal matters, and medications. Disposable items used in hospital are to provide safe working environment and safe equipment. The variety of items available for use is huge, and the recent study identified that trusts across the UK purchased 652 different types of rubber gloves. Gloves are worn for several reasons, predominantly to protect the hands of hospital staff from contamination and reduce the risk of passing microorganisms from a patient to a staff and vice versa. Regulations provide guidance to staff as to when to use gloves during patient contact. Any contact which bring a risk of exposure to contaminants, invasive procedures, and sterile sites mean that gloves must be worn at all times. Gloves are only to be used as a single use, must not be washed or used again, and must be disposed or after use. Change of gloves between different patients is of paramount importance, as in change between different treatment of the same patient. Policies also state that any allergies or sensitivity to latex found in gloves must be documented, and alternatives must be available for use. Face masks are predominantly found in surgical areas of hospital to aid in the prevention of wound contamination from microorganisms in the nose and mouth. The use of face masks in hospital within the UK is inconsistent due to the lack of conclusive evidence as to their effectiveness at preventing the spread of microorganisms. Previous studies have demonstrated that no significant difference are seen in the surgical site infection rate between staff who wear face masks and staff who do not. The same rules apply to disposable plastic aprons and full body fluids repellent gowns. The use of plastic apron in hospitals has been assessed, and it has been found that microorganisms, for example, Staph aureus, can attach to plastic aprons. Blending these two fibers together produce fabrics which have a good durability and comfort properties. They are required to provide adequate protection to the wearer when in use. Scrub suits are most commonly found in theater areas of hospital. Scrub suits are to be worn only in a theater area and must be sent for laundry in-house. Common practice also stipulate that should a member of staff need to leave the surgical area, the wearing of scrub suits in surgical setting is necessary to prevent. Uniforms are worn by staff to carry out their daily duties while conveying a professional image. To comply with these requirements, as far as possible, options available include wearing dress or a tunic and trouser combination. There is no specified time for the reissue of uniform clothing. The majority of staff have their uniform for more than 18 months. Uniform clothing is readily available from varying companies. It is not uncommon to see staff wearing different colors and style combination, no different wards in the same hospital. Patient gowns are worn to provide comfort to the patient during their stay in hospital. They provide access for either pre or post-operative treatment. Previously, gowns have been deemed to provide little dignity as design can have gaps in the back from top to bottom of the garment. Patient gowns are most commonly reusable and are laundered the same way as scrub suits. Concerns surrounding infection are held by the many of the public. There can often be negative comments in the press related to the spread of infection and death of patients. Rigorous cleaning procedure, deep cleaning during infection outbreaks, laundering at high temperature. PPEs provide a required barrier between staff and patients to protect them from harm. However, the survival rate different due to the variations in inoculum quantity. With inoculum quantity of 2 log survival staphylococcus in cotton was 5 days and compared to 16 days with 4 log canoculum. This was substantiated by a study which concluded that microorganisms survive on various surfaces. However, non-confluent growth was seen on fabric, solitary polyester, acrylic upholstery, and vinyl upholstery after 7 days. There are 200 antimicrobial agents, but very few are suitable for use in textile where they are needed to be used. it has to be effective, safe, low environmental impact, durable, easy to apply, have no effect on properties of the textile, and acceptable cost. Antimicrobial textile can act in two distinct ways, by diffusion or by contact. There are four main groups that are used in textile: metals, metal salts, ammonium salts, oxidative properties, like ethylamine, and organic molecules. Commercial antimicrobial coatings are readily available. A popular antimicrobial finish in the healthcare market is quaternary ammonium compounds. The technologies claim to work by fixing nano coating in the fabric surface, which deactivate the microorganism on contact with coating. Silver has also come to the forefront for the use of healthcare applications. It can be used as a silver-coated polyester yarn. There is no specific British standard for testing the antimicrobial efficacy of textile items. The American Society of Testing and Material, there are methods which have been developed to determine the effectiveness of antimicrobial treatment. It also specify how to carry out the AATCC. The Japanese standards also test for antibacterial activity and efficacy of textile products. Important for decontamination sterilization technique, crucial in reducing the risk of cross-contamination of microorganisms. Physical sterilization methods include heat, radiation, and filtration. Protective clothing used in hospital generally arrive packages. Autoclaving is a common method of heat sterilization. Sterilization can also be achieved by liquid and gases. In comparison, disinfectants are used for the cleaning of items which are heat sensitive and cannot withstand sterilization. Due to the cost of equipment, radiation methods of sterilization are limited to specialist or large industrial facilities. Reusable items such as bedding, uniforms, scrap, and patient gowns are laundered on a regular basis to ensure safe removal of microorganisms from the item. Single-use items are disposed of without being laundered and decontaminated because items are normally insaturated. Industrial laundering in the UK is carried out under controlled conditions. Temperature during process reaches 71 Celsius for 3 minutes. When the product arrives at the laundry, they are separated out according to how they have been packed at the hospital. White bags indicate general non-infected linens. Green bags indicate items which have been used in theater. And red bags indicate infected linens. It is not uncommon today society to see nurses wearing their uniform in public places. Concerns arise as domestic washing machines are not as easily temperature controlled as industrial machine. Monitoring of home laundering is also far more complex than industrial laundering. In healthcare establishments where uniforms are laundered by employee at home, a tax relief payment is available. The use in-house laundry facilities ensure that the clothing can be safely thermally disinfected and risk of cross-contamination are reduced. In terms of end-life initiatives for textile use in healthcare sector, recycling and reuse options are not the main focus. This is for a variety of reasons, which include cost, knowledge, and ease of implementation, but predominantly for infection control purposes. This is for a variety of reasons, and items from this sector would need to be safely decontaminated and not cause a cross-contamination. Items which enter the mainstream reuse route through initiatives such as charity shops. Uniform could be stained or damaged, which make them unsuitable for resale. The focus on sustainable end-of-life options in the textile sector lean towards high-street fashion and clothing, where with reuse and upcycling being preferred option. The successful recycling or reuse of healthcare textile items would not reduce this impact, but prevent further addition to by reducing the number of items which are incinerated or sent to landfill sites for disposal. Healthcare waste is defined by the United Hospital NHS Trustee. This is inclusive of uninfectious waste, which is produced by wards or within the community. There are various color coding systems in operation for the segregation of waste. Infectious waste, including contaminated dressing and PPEs, is to be disposed of into orange sacks and saturated on removal from the hospital. There are strict rules surrounding how waste bags are disposed of to prevent infection spreading and cross-contamination. Waste management policies stipulate that waste bags are to be replaced on a daily basis or, if required, 1 2/3 full. It is common practice that in hospital, the colored bag which identify clinical waste or to be unsaturated is favored choice for discarding, for disposal, and single-use items as it ensures safety, contamination, and reduced risk of cross-contamination. So conclusion, washing at low temperature becoming an increasing feature today, society, a push from government to reduce consumption and waste, prolonging the life of clothing by washing at lower temperature. Less harsh detergents could provide sustainable solution for the healthcare industry. There is a much more work to be done in antimicrobial finishes. And durability of these finishes and compliance with the relevant standards which are fit purpose needs to be fully assessed. Any question? أي سؤال يا أخوان؟ شكرا هيفا، شكرا الهنوف. Okay, we'll move to thank you Azza Ragad, thank you Bayan. We'll move to a video presentation, which I hope it will be helpful about PPEs.
Put on boot covers. Perform at hygiene. Put on inner gloves. Put on coverall. Make thumb holes at the border of the cuff and sleeves. Put on N95 respirator. Cup the respirator in your hand with the nose piece at your fingertips, allowing the ties to hang freely below your hand. Position the respirator under your chin with the nose piece up. Pull the top strap over your head, resting it high at the back of your head. Pull the bottom strap over your head and position it around the neck below the ears. Hold the nose piece using 2 fingers of each hand to the shape of your nose. Perform seal check. Inhale deeply. Exhale sharply. Put on hood. Put on outer apron. Put on outer gloves. Put on goggles. Inspect the PPE to assess for visible contamination, touch, or care before starting learning. Disinfect outer gloves.
I'm disinfecting outer gloves.
Remove apron.
I'm using my apron.
Inspect the PPE again. Disinfect outer gloves.
I'm disinfecting the outer gloves.
Remove covers.
Removing my boot covers.
Disinfect outer gloves.
I'm disinfecting the outer gloves.
Remove outer gloves.
I'm removing the outer gloves.
Inspect and disinfect inner gloves.
I'm inspecting the inner gloves and will disinfect them.
Remove goggles.
I'm removing the goggles.
Remove goggles by lifting the back of the goggle strap over your head and pulling out then away. Avoid touching the front surface of the face shield or goggles. Disinfect inner gloves.
I'm disinfecting the inner gloves.
Remove hood.
Removing the hood.
Disinfect inner gloves.
I'm disinfecting the inner gloves.
Remove coverall and discard.
I am removing my coverall.
Avoid contact of scrubs with the outer surface of the suit during removal. Lift chin. Find the zip at the level of your belly. Carefully trace your fingers up to find the zip tab and fasteners with one hand. Hold the outside of the top of the suit with the other hand. Unzip or unfasten the coverall completely before rolling down and turning inside out, touching only the inside of the coverall. Disinfect inner gloves.
I'm disinfecting the inner gloves.
Change inner gloves.
I'm changing the inner gloves.
Remove and discard gloves, taking care not to contaminate your hands during the removal process. Perform hand hygiene.
I'm now performing hand hygiene.
First, grasp the bottom elastic strap, then the top elastic strap. Remove without touching the front of the N95 respirator. Discard the N95 respirator. Disinfect gloves.
I'm disinfecting the gloves.
Disinfect washable boots.
I'll now be disinfecting the washable boots. I'm disinfecting my washable boots.
Disinfect and remove gloves.
Disinfect.
Perform hand hygiene with alcohol-based hand rub.
I'm now doing hand hygiene.
Inspecting for any contamination.
Okay, that was a slight video to any question, يا اخوان? We are moving to our last presentation for today. This lecture considered how designing the built environment to incorporate a new and existing technologies can help control the presence of microorganisms in hospital. It discussed how modifications to ward layout, the patient environment or specific surface can improve hand hygiene and environmental cleanliness. New innovations include temporary isolation rooms, waterless commodores, and light-activated antimicrobial coating are described. How existing technologies and materials are now being used to reduce environmental contamination is also discussed. The advantage and disadvantage of these new and existing technologies are highlighted. نخلص على الساعة 10 بمشيئة الله، هذه آخر محاضرة. Organisms have been also isolated from services within the wider world environment, raising questions about the adequacy of a cleaning regimen and hand hygiene compliance. Nonetheless, many of these services only come into contact with patients' intact skin, which is highly effective barrier against microbes, and such they are considered non-critical. A few studies have been able to demonstrate that a solid environment is actually hazardous to patients, or that improved or enhanced cleaning result in lower rates of transmission. Nonetheless, with the advent of molecular techniques, there is increasing evidence to suggest that environment is a potential reservoir of infection. Initial equilibrium levels, type of surface material, and the presence of moisture in organic and organic soils can all influence the ability of organisms to survive on an inanimate surface. Coagulase negative staphylococci are ubiquitous in the world environment. The duration that staphylococci, including Staph aureus, are thought to persist range from 7 days to 7 months. MRSA is readily transmitted on hands, and although there has been considerable success in reducing its prevalence in recent years, MRSA remains an important cause of wound infection and bacteremia. Enterococci are also frequent cause of nosocomial bacteremia, as well as urinary tract and wound infections. Although normal colonization of the gastrointestinal tract can lead to endogenous infection, enterococci also transfer between patients. The presence of recognized and unrecognized carrier on a ward can lead to widespread dissemination and persistent enterococci within the environment. Survival of Pseudomonas aeruginosa and TAPS has recently been implicated in outbreaks of bacteremia in neonatal units, and it is recommended that routine monitoring of Pseudomonas contamination is carried out in neonatal critical care and hematology units. Inadequate hand hygiene after patient contact and or after contact with the patient surrounding can contaminate local environments. The modification toward layout, the patient environment, and or specific services or materials can help improve hand hygiene. Modifications toward layout can also help an environment cleanliness and may help to design out hospital infection. Many studies have demonstrated that architecture can affect health. Hospital environment can play a role in reducing stress, making patients safer, promoting better outcome, and enabling staff to do their jobs more effectively. This has been demonstrated by increasing the number of beds in a ward while maintaining the patient-staff ratio. The recommended distance between beds has gradually increased. However, this is usually related to ease of access in emergency and use of hoist rather than infection control needs. Architects will adhere to government legislation, but not necessarily guidance, and their knowledge of infection control principle is limited. No air from BBVL isolation room should reach the ward or corridor. For example, ideal isolation provision requires the use of positive pressure ventilized lobbies, which allow patient requiring source of protective isolation to be housed without adjusting the ventilation. However, concerns of cost and the space may lead to architects to dispense with such lobbies, making pressure differential less easy to maintain. The design of near patient and or high contract surfaces can ensure ease of cleaning and or reduce bacterial reservoirs, yet the material used are generally selected on the basis of function. The main requirements are smooth sealed surfaces with no holes. The surface can differ significantly in terms of the number of bacterial transferred to and from hands. Evidence-based design as defined by Center of Healthcare Design. However, the complex and multifactorial nature of nosocomial infection means there is currently a lack of evidence linking their prevention and modification to hospital design. There is an incentive to develop and evaluate innovative preventive measures that aim to break the chain of transmission, and the level of credible research is increasing. Hand hygiene is one of the most important means of preventing nosocomial infection. Yet adherence to recommended hand hygiene procedure is often poor. It is recommended that one of available no more than a few cases from any patient. They must be prominent in the ward and be positioned so that one is visible whichever may staff member turns. Ease of access does not improve hand washing techniques. As a result, automated sink controlling water flow, soaps, dispensing and hand washing duration have been evaluated either as a standalone models or as a part of temporary isolation unit. Any improvements in hand hygiene compliance have been attributed to a novelty of use. However, perceived dam pressure often results in staff opting to use manual ward sinks in preference to automated machines. Sustained improvement in hand hygiene compliance require greater intervention than just a provision of adequate and accessible hand washing facilities. Nonetheless, automation does allow the hand washing techniques to be non-touch. Tap handles can become heavily contaminated and sensor taps have been introduced. Materials commonly used in modern plumbing system include synthetic rubber materials such as ethylene or propylene monomer. In response, some hospitals have replaced sensor tabs with manual tabs, and the new designs of tabs are becoming available with reduced lid space and easier disassembly to allow for cleaning. Although tap outlets are supplied with water at safe, comfortable temperature of 42, the lack of thermal control facilitates the survival of microorganisms and encourage biofilm growth. The design of the sink should minimize splashing. If water from the tap is allowed to flow directly into the sink drain, Pseudomonas biofilm within the drain can become disrupted. Hand drying is an essential step in the hand washing process. Towel dispensers, especially when located in sink splash zone, have been identified as a potential source of contamination. Studies have demonstrated that bacterial transfer between towel dispenser and hand can occur if either one is contaminated. The transfer of bacteria from hands to surfaces increases in the presence of moisture. Modern ultra-rapid dryers that allow hands to remain stationary during the drying process have been shown to be superior to warm air dryer for reducing bacterial transfer post-wash. Air dryers are unlikely to generate airborne microorganisms. However, they can be noisy. And usually ultra-rapid dryers are not often installed in hospital wards. However, they can be noisy, and for a ward environment to be conducive to sleep, environmental noise must be kept to a minimum. The risk of hand decontamination with Pseudomonas following hand washing has resulted in a recommended use of alcohol gel after hand washing. Hand rubs should be used at the point of care at wall-mounted dispenser rather than being placed exclusively at the sink. Should be positioned in convenient locations for healthcare workers based on the design, layout, and workflow of the ward. Although hand wraps can reduce the number of bacteria present in hands, the dispensers themselves can become contaminated, particularly those areas most commonly touched. Automatic touch-free dispensers are available and have been shown to increase the frequency of hand hygiene. Modifying the bed space can improve infection rates. Infection rates are lower when patients are in single rather than multi-bed bays. Single rooms reduce airborne transmission by providing a physical barrier and the positively or negatively pressurized environment as required. A fully single room hospital has a maximum flexibility of patient use and better contaminant of both airborne and contact spread within the bed space. This is a contributory factor to a low incidence of HAI in hospital in a private sector. Many hospitals lack sufficient single rooms to accommodate all patients requiring source isolation. A temporary isolation room has been designed as a potential solution to the lack of available single rooms. A unit designed to provide a physical barrier as well as some airborne isolation can put up in a bed space within 2 hours. It comprises aluminum frame with clear plastic sheets attached to either side. A remote control motor is used to pull opaque sheets across the privacy. At the head end, a plastic apron abuts the wall. At the foot end, there is a hinged flap with alcohol gel dispenser. An open airway protected by the stream of high efficiency particulate air. The efficacy, usability, and accessibility of this temporary isolation room has been assessed. In contrast to textile isolation, the temporary units allow staff and visitors full of easy access to the patient via the air door. The prototype air door was not an efficient means of preventing air leaving or entering the room. Use of the unit allowed patients requiring source isolation to leave intensive care area, but saving where offset need of engineering support to maintain full operation. Custom-made semi-permanent rooms kits are now being leased to hospitals by one commercial company. Although not suitable for airborne isolation, simple screens between beds have been shown to be as effective as temporary single rooms in improving hand hygiene compliance. They can also be used for patient dignity and gender separation purposes. Smart glass screens become opaque when a small electric current is applied. Although they are easily cleaned, they are heavy and difficult to maneuver. Nevertheless, the technology is being used for fixed dividers and to replace Venetian blinds used at windows for privacy purposes. As a result, they have been more widely introduced into hospitals. Source isolation requires dedicated hand washing and toilet facilities. For such amenities to be available to patients isolated in temporary units or in cohort bays, portable sink units and toilet are required. Commodos can become heavily contaminated, which are difficult to clean and have been identified as a source of infection. Designs were refined by interaction with expert panel, which included nurses, microbiologists, and infection control practitioners. A Commodos has been produced that is easy to clean, confirmed both by staff questionnaire and laboratory assessment. However, there are still concerns regarding odors, disposal of waste, and exposure of patients to contaminated aerosol and splash. Portable waterless toilets have been designed to avoid the dissemination of odor and infectious aerosol. To aid disposal of waste, a plastic sleeve is drawn into toilet, heat sealed around fecal matter and cut, dropping into a drawer below. In addition, smooth contours facilitate cleaning. Electronic patient records are more widely used. Staff are increasingly using computer in their management of patients. Computer keyboards are not easily cleanable, particularly between keys. As a result, they can become heavily contaminated. Inadequate or infrequent cleaning allows microbial contaminants to survive and persist on environmental services. Whilst posing a little direct risk to patients, computer keyboards can act as a source from which healthcare workers can contaminate their hands. Nurses recording patients' observation and medical staff passing from keyboards to keyboards, usually without hand hygiene, may transmit pathogens to other patients via contaminated computer keyboards. Self-sanitating keyboards that utilize ultraviolet light have been developed. One keyboard automatically retract into enclosure where it's bathed in ultraviolet radiation. Both disinfection systems are triggered by the movement and or an activity of the user. In comparison, continual disinfection exposure to ultraviolet rays emitted from handheld devices is likely to be shorter and more inconsistent. Smooth sealed keyboards are available, some with a visual alarm to promote cleaning. The alarm is activated in adjustable timer, typically 12 hours for most clinical locations and 3 hours for places where the transmission infection is more critical. However, visual alarm is easy to ignore and if cleaning compliance is poor. In an attempt to improve cleaning compliance, software that reinforces the alarm by causing the moving window to appear on a monitor screen has been developed as currently under trial. Reducing level of MRSA in environmental services reduce the level of MRSA in the hands of staff. It should be possible through well-constructed, validated cleaning programs to effectively reduce the environmental load. Surfaces may be difficult to clean, or they may be left unclean, particularly if compliance is not closely monitored. As a result, it may be more cost-effective to modify services such as efficiency of cleaning is improved and or the adherence of transfer of survival of pathogens is reduced. Antifouling coatings, bed rails are one of the few services in the world environment that are touched by patients, staff, and visitors. As a result, they can become heavily contaminated. Microfiber cleaning reduced microbial number to below detectable levels. However, whilst the use of polyester coating steel may be appropriate for bed rails, such as coating may not be suitable for other materials. In the absence of cleaning, microorganisms can survive to resistance services for many weeks. Organisms may survive the cleaning process and or surfaces may become recontaminated immediately or sooner after the cleaning. Copper is known to exhibit antimicrobial properties. Copper is a catalyst for the generation of reactive oxygen species, which can cause oxidative damage. Disintegration of DNA and depolarization of the cytoplasmic membrane may also be major effect. However, pure copper vanish easily and making service aesthetically displeasing. The high reactivity of copper means such soil elements rapidly absorb the surface. To prevent the build-up of soil and bacterial cells, copper surfaces must be cleaned as effectively as frequently as non-antimicrobial surfaces. Other disinfectants may form a layer between the surface and bacteria, reducing contact with antibacterial effects. Silver is widely used as an antibacterial surface coating and or additive to paints, textile, and liquids. But at the temperature and the relative humidity typical of world environment, they exhibit no meaningful antimicrobial effect. Coatings have been developed that produce reactive radical species when activated by visible light. The activation of photosanitizers results in production of radicals such as superoxide, hydroxyl radical, and singlet oxygen. Coating containing photosanitizers have been shown in laboratory studies to be effective against a range of microorganisms. Hospital privacy curtains are frequently contaminated with pathogenic bacteria. Curtain contamination could be reduced by using light-activated antimicrobial materials. So in conclusion, contact detection and ultrasound or radio frequency tracking of staff and patient movements has been used to identify high-risk areas. However, analysis is complex and there have problems with staff rights to privacy. The application of nanotechnology to modify service characteristics may also help to reduce bacterial adherence and survival. Without robust efficacy data, manufacturers have difficulty marketing their products, and infection control practitioners have difficulty in conducting reliable cost-benefit analysis. Innovations to help control presence of microorganisms in hospital range from easily cleanable lights, pulls, the doors handles. However, to demonstrate reduction of infection rates is more difficult. Choices made during the design, build, or refurbishment of a hospital could be significantly affect the ability to control the spread of nosocomial pathogens. That was our last presentation for today. أي سؤال يا أخوان؟ شكرا لكم جميعا، وإن شاء الله تكونوا استفدتوا. نتمنى لكم التوفيق جميعا ونراكم على خير غدا بمشيئة الله. بكرة إن شاء الله بعد ما نخلص الكورس هنعطيكم محاضرات PDF بمشيئة الله. إذا في شيء نسيناه أو شيء ما غطيناه بيكون موجود إن شاء الله. نتمنى لكم التوفيق جميعا ونراكم يوم غد بمشيئة الله. إذا ما في أي أسئلة يا إخوان you can leave. في أمان الله ونراكم غدا بمشيئة الله.